oral temperature, and oral temperature is more than the axillary temperature with difference of 0.5 to 1 degree Fahrenheit. And normal range of body temperature is 36.6 to 37.9, and it is not constant in the morning and the evening, while it is highest in the evening, early evening, and lowest in the early morning. And this difference also present during the time of fever. We know hyperpyrexia means rectal temperature more than 40 degrees Celsius, while hyperthermia is fever more than 41.5 degrees Celsius, with important point should be there is no change in the hypothalamic set point. So it is due to change in the environment. So if patient is a very hot environment, then patient may be hypothermic, hyperthermic. So temperature, whether patient had fever or not, it depends upon the how much heat is produced and how much heat is lost. And there are different mechanisms causing this. So there are exogenous pyrogens like infection, pathogen, toxin, drugs. All this may directly stimulate PGE2, or they may invade the body and cause endogenous stimulation of the pyrogens like interleukin 1, interleukin 6, TNF alpha, interferon beta and gamma, leading to production of PGE2, which change the hypothalamic setup point to the higher side and generate the different mechanism in the body to produce the heat. That means if there is an infection or internal pyrogens, and if you want to decrease the fever, you have to use the drug which act at the PGE2 site. So what are the different mechanisms which generate the heat? That is by the contraction of the somatic muscle causing shivering or rigors, or causing the temperature generation in neonate. There are the brown adipose tissue which are used for the heat production, and there is a vasoconstriction of the vascular smooth muscle conserving the heat lost to the external part of the body, and heat is gone to the internal part of the body. Similarly, there is a piloerection of muscle, hair follicles, which causes the heat trapping and keep our body warm. But in hyperthermia cases, what happens? There may be environment temperature may be very high, like in the summer season, or if the person is working in a very hot and humid environment. Similarly, if there is an absence of sweat gland, or there are no sweating in the patient, if the patient is taking some anticholinergic drug, and this causes there is no loss of the temperature of the body, and patient may get high fever, and this time it is known as a hyperthermia because there is no change in the hypothalamic setup point. And in this type of patient, if you use any dose of antipyretic, it is not going to be useful, and you have to try the different method like cooling of the body to decrease the temperature of the body. So what is the difference between hyperthermia and hyperpyrexia? Temperature in hyperpyrexia more than 40 degrees Celsius. In hyperthermia, it is more than 41.5 degrees Celsius. Hypothalamic set point is changed in hyperpyrexia, while it in hyperthermia, it is not changed. Causes in hyperpyrexia are usually infection, toxin. Skin is hot and moist, and skin is hot and dry in the hyperthermia. So if you are getting the dry skin, axilla, especially if the axilla are dry, you know patient may be hyperthermic. And antipyretic usually work in hyperpyrexia but may not work in the hyperthermia. So there are different terminology. Depend upon that, we may label the fever differently. So fever without focus or fever without localizing sign, when the fever is less than 1 week and after careful examination, you are not able to find what is the locus or what is the focus of the fever. And fever of unknown origin, also known as a pyrexia of unknown origin, is said to be there when fever more than 3 weeks duration. Important thing is fever should be documented. So if the fever is documented and it remains for more than 3 weeks duration in outpatient setting, or otherwise if fever more than 1 week duration in hospital setting, and after through evaluation, if you are not able to diagnose the fever, then it is known as a fever of unknown origin. Periodic fever. The term periodic fever narrowly used to describe fever syndrome with a regular periodicity. Means if there is a one episode of fever and parents will tell you when the child going to have the next fever episode again and for how many days it is going to last, then you should consider whether the child is suffering from periodic fever. Then there is a factious fever. Factious fever or self-induced fever may be caused by intentional manipulation of the thermometer or injection of pyrogenic material. In our Hindi movies, this concept is used many times. Pseudo FeO, that is the fever of unknown origin, is defined as successive episode of benign self-limited infection with fever that patient pursues as one prolonged fever episode. Means patient may have some viral infection, they get cured, and after 2-3 days, patient may have another viral episode, and parents may feel the patient have this continuous episode of fever during all this day. That is known as a pseudo fever. Fever less than 3 days in well child usually not required laboratory evaluation and antibiotics, but careful documentation of fever and SOS antipyretics is all that required. My humble request to all of you, don't do any investigation in first 3 days of fever. Whatever the degree of fever there may be, if the patient is well in between the fever. Because sometimes rather than helping it, it may distract you. Some points you should remember that fever is a symptoms and not a disease. Fever, we always consider fever equal to infection, but it is not. We have seen lot of sessions ongoing during these 2 days where fever is due to malignancy, rheumatological conditions. Sometimes there is a hypothalamic involvement, which is again going to cause the fever. So fever is not equal to infection. Similarly, infection, if fever is due to infection, it is not always a bacterial infection. So fever is not equal to antibiotics. It may be viral, it may be fungal, sometimes it may be parasitical. So we have to remember this thing. Diagnosis in majority of fever cases is by the history and careful examination and not by the laboratory investigation. Laboratory investigation are help us to reach the diagnosis what we thought on the clinical basis and rule out the other diagnosis. We have the case where patients come with the history of fever from another hospital, fever of 15 days. On history, by carefully taking the history, I suspect as the cause of the systemic onset GI on the onset. But when we send the investigation, patient comes Vidal positive. So he is treated as a enteric fever for next 4-5 days. After 5 days, patients become suddenly hypotensive. Her platelet counts goes down, and that patient was shifted to PICU. Again, the lot of set of investigation was done. And as the dengue period is going on, dengue was also sent. And dengue IgM also comes positive. Now he is treated as a dengue fever. But our initial suspicion was the case of a systemic onset GI. Now this case was discussed with the sir, and we have found out this patient is actually suffering from, our first diagnosis was right, is suffering from the systemic onset GIA with complication of macrophage activation syndrome. And this dengue positivity and the Vidal positivity, they are the falsely positive because of the hypergammaglobulinemia. So we have published this case, that is the never fooled by the positive serology. They may fool you. So don't do the investigation at the first place. Do investigation what you think possibility of the diagnosis. So blanket lab investigation most likely leads to the misdiagnosis of the fever. Antipyretics should not be given round the clock. So 8 hourly, 6 hourly, 4 hourly antibiotics should not be given. It should be given SOS rather than the round the clock basis. So evaluation of fever, first step is the documentation. It is a very important step because in pediatrics, most of the parents will complain की त्याचं शरीर थोडं गरम लागतंय, त्याला ताप आहे. But whether child has really fever, so there are two methods. One is the touch method and second is the thermometer method. We should ask the parent to document the fever with the thermometer. If the parents come with the history of 15 days fever and they have not documented the fever, and if they go to the general practitioner and he also not documented the fever and fever is not reduced, first thing you want to know whether there is a really fever or not. If they doesn't document, how you will going to know whether there is fever or not? Dr. Bhupesh, you can tell. So ask them whether अंग कसं गरम लागते. जर ते म्हणताय की तव्यासारखं तापलेलं अंग आहे, चटके लागताय, then you know there really the patient has a fever, or if there is some associated signs or symptoms. But if they say कि थोडं अंग गरम आहे, then there may be fever or there may not be fever. You have to admit or you have to observe the child and document the fever. Then second thing, whether the child is sick or well. If the child is sick, then obviously you have to do investigation or you have to admit the child. But if the child is well, then you may watch the child and you may do the investigation once you have clear what you are going to thinking of. Then this is the important steps, whether the child is belong to the high risk group or not. Because if the child is belong to the high risk group, then you may be worried and you may investigate early rather than waiting. So what are the high risk group? They are if the child is malnourished, neonate, immunodeficient, and last point is if they are from the remote area or they have the poor understanding, then you may require to evaluate them early. There are three basic types of fever, that is the continuous, intermittent, and remittent, depending on whether the fever touches the baselines or not, and what is the fluctuation of fever in between fever spikes. Different type of fever like tertian fever, quartan fever, quotidian fever, depend on when the fevers come back. And we all know that fever pattern may be unreliable due to antipyretic use. So these are the classically described fever pattern, but it may be unreliable. But if you use SOS basis of antipyretics, you may see this type of fever pattern, and it is really going to help you in your diagnosis if you get this typical fever pattern. So if you can differentiate between viral and bacterial infection without any investigation, because there are not much investigation which can be differentiated between viral and bacterial. But on history, approximately 70 to 80% times you can differentiate whether the fever is actually viral or bacterial in initial few days. So if there is at initiation fever is very high grade, it decreases over 3 to 4 days, multisystemic involvement, child is well in between the fever. If there are more symptoms than the signs, then you know most probably you are dealing with the viral infection. If at the onset fever is less and it is gradually progressing, if it is localizing to the single system, if the child is well and then progressively becoming sick, then you know it is a bacterial fever. Then progression is very important. So if their progression is not as you expected, then you have to review your diagnosis. Fever is rash, usually viral, but you have to remember if the rash, you would have to do this glass slide test. And if the rash is non-blanchable, then you have to think whether there is a serious bacterial or rickettsial infection or not. Other history like residential area, history of travel, history of vaccination, past history, similar complaint, history of drugs, you should ask. Ongoing infection during that fever, like dengue fever epidemic, if there are dengue cases of, lot of cases of dengue fever, sometimes you meet ALL or ITP during this dengue fever because our mind is occupied with the dengue fever only. Find a focus. Vitals are vital in diagnosis. Then clinical examination, we have to carefully look for the itcher, for the rickettsial infection. Eye examination is important for the connective tissue disorder. If the fever is less than 7 days in otherwise well child, usually viral. Fever more than 1 month, unlikely bacterial. Find out malignancy or rheumatological or atypical bacterial as a cause. And if patient is able to tell us when the fever is going to come next time, you know that is a periodic fever. Whether fever is friend or enemy, fever is our friend because nature has kept it till date, and there is a complex mechanism which regulate the fever. So we should tell parents it is a friend of our, and we should not afraid of fever. Take home messages. Fever is common reason for consultation of pediatrician in sick child. Knowing pathophysiology help to identify possible cause and probable treatment. All fever are not bacterial. Antibiotics should not be first day prescription in immunocompetent child. Don't give them for first 3 days. I am not going to say ki 7 din mat do, 10 din mat do. But if you try to stop yourself for first 3 days only, then approximately 50% of antibiotic prescription is going to be down. Most of the diagnosis is on history and careful clinical examination. Investigation help to prove or disprove our diagnosis. And thank you for your kind listening.
Thank you, sir, for such an interesting talk and decoding all the basics of fever for all of us. I request the chairpersons to please give their comments. I request
Hello. Thank you, sir, for this extensive and lucid talk on fever. Fever is the commonest symptom for that patient comes to our general pediatricians with us. And whatever he has told us, fever, basic carry home message for us is you go for the etiology and diagnose it first. And secondly, fever is not the only indication for IV ceftriaxone. That is what the take home message is when you have to use antibiotics and what is the indication for fever. Thank you.
Thank you, sir. I request Dr. Datta Patil, sir, to please felicitate Dr. Naresh Taide, sir. For our next session, I humbly invite Dr. Atul Kulkarni, sir, on the dais. Having done with fever, the other sibling of the fever is a rash, or may have a fever without rash, but it is unusual to have a rash without a preceding fever. The type, the pattern, and the duration of the rash gives us a clear insight into the cause by and large. Dr. Atul Kulkarni, sir, will run us through some interesting spotters in the next session. Sir, please.
Good afternoon, everyone. At the outset, I will say heartiest congratulations to Ramakant, Dr. Sharmila, and entire MAHAPEDICON team for arranging such a wonderful conference. For next 15 minutes, the scientific committee has given me the topic of spot the hotspot. So I am going to run through a rapid fire of spotters, and you are going to answer the questions. So this is an 8-year-old girl with a fever, sore throat for 2 days. Rash appeared on the body on this day 2. When I look at the tongue, what is this? Which strawberry, white or red? Because there is importance. Yeah, it is white strawberry. And which condition we get white strawberry? Scarlet, right? And later on, after third, fourth day, it becomes a red strawberry. What other conditions we get a strawberry tongue? Kawasaki. One more. Toxic shock syndrome. Sometimes mouth breathers, even some viral conditions also we have to keep in mind. So not always it is a serious. So this child had a rash. So what is this called? Can you see here? What it look like? Yes, sandpaper. So this is a typical of scarlet fevers. So sandpaper rash, perioral pallor. This is another clinical clue. And what is this? Can you see here, reddish line here? This is called as Pestius line, which is there in the cases of scarlet fever. So these are the clinical clues for the diagnosis. And what is this? Skin peeling, which occurs at the end of first week in scarlet fever. So this is scarlet fever, and these all are the clinical clues for the clinical diagnosis of scarlet fever. Spot, what is this? Looks scary, no? Yeah? Yes. And foot mouth. Nowadays, we see a lot of patients with. So whenever you see anything on the periphery, one should remember either spotted fever, hand, foot, mouth disease, erythema infection, multiforme, bacterial endocarditis, and atypical measles. So this child had a necrotic blisters, and it was severe form of hand, foot, mouth disease. And last 3-4 months, we all have witnessed hand, foot, mouth disease in various forms. This is a hand, foot, mouth disease. Also now it is not restricted to hand, foot only. It is coming on the elbow, on the shoulder, on the knees, on the buttocks, and even some patients with extensive hand, foot, mouth disease, commonly Coxsackie A61. Whenever associated with encephalitis, one should enterovirus 71 is the cause. 4 years child had a rash over the face. I'll show you another picture. What is this? You can see the redness or the slack tip. What is the condition? Yes, pyroviral infection, what we call it the fifth disease or erythema infectiosum. And this is, as parvovirus is a pro-erythrotropic virus, it can cause complications in the, especially patients with the hematological conditions like thalassemia. It may flare up the aplastic anemia and so on. This 10-day-old newborn, rash over the body, decreased feeding. Mother had similar rash before delivery. What is this? Neonatal varicella. Okay, neonatal varicella. It can be when a mother gets infection in the first trimester, you get a congenital varicella, and if perinatal infection occurs 5 days before or 2 days after birth, it is a neonatal varicella. Mortality is very high, so you have to treat with acyclovir. Any prevention? What we can? How can? When can we prevent? Immunoglobulin. If not available, varicella zoster immunoglobulin not available. What we can use? IVIG 400 milligram we can use. Right. 3 years child had a rash over the body 10 days back. Now child has come with a high fever, tachycardia, and skin lesions in the groin and supraclavicular lesion. You see this child? You can see the lesions here on the chest. These are the lesions on the face. And there is another lesion here. And here there is another lesion. So what is this? This is chicken pox. Okay. And this child had chicken pox 10 days back. And what could it be? Here and here. Complications of chicken pox. Necrotic fasciitis. You can see that the black skin here and woody firm. So this requires surgical department. This child had a staph positive, came staph positive also. Came in shock with necrotizing fasciitis. This is one of the complications of chicken pox. This, what is this? This child had epistaxis, even hematuria, bleeding, subconjunctival bleed, and various lesions over the face. This was a hemorrhagic varicella. 18 days old newborn presented with irritability, mild fever, not feeding well, skin lesions like this. What is this? Yes, SSS, what is it? Classical SSS. You can see the peeling of the skin, scalding all over the body. And this is an older child with SSS. This 5-year-old male child had a fever since 6 days, rash since 3 days, irritability and pain in legs. You can see a rash over the face, on the arm, on the palms. So what is the diagnosis? Yes, rickettsial fever, because extending on the palms, already we have discussed the peripheral lesions. This is palpable purpura. This child was coming from the rural area. There was history of contact with the animals. IgM came positive. I will just show you. This is a classical purpuric rash in rickettsial infection. On the palm also, on sole. This is a palpable purpura. This is a classical edema you get in case of rickettsial infection. Classical edema with rash. Sometimes you may get a severe necrotic rash like this. What is differential for this? If you see rash like this, meningococcemia, yeah. Meningococcemia may present with a severe necrotic rash, or TTP can present like this. How to differentiate meningococcemia? You will get a necrosis in the center of the rash. Rash is usually present in the territory of inferior vena cava. In rickettsial, you may get on the face also. Once rash appears in the meningococcemia, child deteriorates rapidly, go in hypotension, coma, shock. So this is, but in rickettsial infection, you may get some time. So this is gangrene of finger. This is what is called as Kahn's-Kappa disease. In Vidarbha, this is called as Kahn's-Kappa disease, because this is in the rickettsial infection, you get a gangrene of the earlobe, and that there occurs a auto amputation. So Kahn's-Kappa disease. What is this? Scab is just off. That's why it is looking white. Yes, somebody said ischia, right? So this is classical ischia in case of scrub typhus. Even in case of Indian tick typhus, we can get ischia. But the ischia is very common in scrub typhus. Whenever you get a child without fever, without focus, search for ischia, because that is, even in our area, we are getting scrub typhus and even Indian tick typhus. So what are the typical sites for ischia? You have to look at least in the hairline area, axilla, groin, because most of the 75% of the incidence of ischia is in this area. So you have to search for the ischia, especially if child comes with a fever without focus. And you can get a clinical clue for the diagnosis of scrub typhus or Indian tick typhus. So this is very important, where to look for ischia. This 18-month-old child had a fever and rash, 2 days. Rash appeared 12 hours back. She was very cranky, febrile, so was admitted, sent for the investigation, and child started deteriorating rapidly. And this type of rashes was there. So what is this? Same, I just mentioned you. Necrosis in the center, and child is deteriorating with a rash. One should think of a meningococcemia. 3-month-old child had a fever for 2 days, very high fever, irritability. Child was treated on the OPD basis. On examination, child was febrile, there was tachycardia, there was rash, there was flushing, and CRT was delayed. What is the diagnosis? Yes, dengue can be one of the. Which are the other conditions which get erythroderma? This is called as erythroderma, flushing of the skin. Toxic shock syndrome, you get typical erythroderma. That is one of the earliest signs, because in the last COVID season, we had many cases of toxic shock syndrome, which presenting with flushing, coming in the shock, tachycardia, some conjunctival congestion, even the strawberry tongue-like. This child had CRT was delayed. On investigation, there was thrombocytopenia, CRP was raised, and NS1 was negative. So what is your diagnosis? CRP positive, looking like dengue, thrombocytopenia had NS1 negative. Any other mosquito-borne infection? Chikungunya, right? This is chikungunya typically present, and in chikungunya you will get a high CRP, not very high, but you can get in the 50s. And typically, this child developed these blisters over the leg. So we sent for chikungunya PCR, it came positive. So this is typical rash of chikungunya. And most of the time you get a history, mother or somebody else in the family having a high fever. You can see the redness of the ear and edema. This is typical. On the faces, you can pick up the cases of chikungunya, just having flushing, redness of the cheeks and on the ear. This is typical. This is called as million ear sign. This is another newborn baby with a flushing. Then acrocyanosis, blisters, typically on the, anywhere it can come on the body. And this is a post-infection hyperpigmentation. This is called a chick sign. Seen in the adults also and seen in pediatric age group also. Even on the face, this is called a chick sign. We may get a pigmentation on the legs also. Now coming to a 6-year male child presented with fever for 5 days, sore throat and rash like this on shin of tibia. Anyone? Shin of tibia, erythema nodosum. Okay, post-streptococcal infection. We can pick up in the clinic, our OPD, and we can get sometimes in patients with tuberculosis also, or certain ducts can cause erythema nodosum. A 4-year-old child had a history of fever, headache, body ache, and abdominal pain, vomiting. Hematocrit was raised. There was ascites, effusion. What is doing? Again, erythroderma, flushing. Typical flushing, which comes in the dengue fever. Typically, this is purpuric rash, which occurs when the platelet goes down around 5 days of the illness. And what is this? What is this? So it is dengue in a recovery phase. This comes in the patient when dengue fever starts in the recovery. So this is typically called as white islands in a sea of red. So in dengue, initial first 3 days, you get flushing. 4th, 5th, 6th day, you get purpuric rash. 6, 7 days, white islands in the Red Sea. So this is a recovery stage of dengue. What is this spot? His shoulder, left shoulder. Child 3 years old child presented with high fever for last 4 or 5 days. Yes. Reactivation of BCG scar. You can see here on the left hand, the left shoulder, there is a reactivation of BCG scar. You seen in Kawasaki. So you may get a very clinical pictures, classical picture. This is a conjunctivitis non-purulent, and there is a typical limbal sparing in the cases of Kawasaki. This is a child with a limbal sparing and conjunctivitis. You get strawberry tongue and cracking of the lips. Another child with a strawberry tongue. Typical faces is, you can just pick up just from a distance, a Kawasaki patient. You get edema of the palms, sole, and typical periangual peeling. In scarlet fever, we saw the peeling was there entire. Here, the peeling starts from the periangual area. This is another child. Perianal peeling is also seen. I had one patient with oncholysis. So onchomyoidosis, same type we are getting now in cases of HFMD also in this season. This is 4-year-old child, history of fever for 14 days. Sick looking, irritable, hepatosplenomegaly. What is your diagnosis? And these lesions on the body. 2 weeks fever, hepatosplenomegaly. Hepatosplenomegaly. 2 weeks fever. ITP will, yeah. Leukemia, yeah. Okay. So this turned out to be ALL. 3 years child with atypical febrile convulsions. Child received antibiotics, but child had second episode of convulsions. Phenytoin was given. Child developed rash, this type of rash on day 4. Yeah. Yes. Yeah. Huh? Right. So child received phenytoin. This was the rash was there on the periphery also, and this was a child on day 6. So developed full-blown picture of Stevens-Johnson syndrome. This is another child with Stevens-Johnson syndrome. So it can cause by post in mycoplasma infection or HSV also. What is this? Diagnosis? Another child came with a very bad, but she was there with us for more than 1.5 months. We could save her life. 10. So there is a, when there is a skin involvement more than 30%, we'll call it a toxic epidural nephrolysis. So this was 10. Any diagnosis? Child was on anticonvulsants for last 8 years. Yeah? Yes. So typical subepidermal calcification, tuberous sclerosis. Just I have put spotter in fever because this child doesn't came with the fever. So this child had a fever on and off for last 3 to 4 months, some muscular weakness and some rash you can see here around the eyes, some lesions of the elbow and even on the knee. This is called a cutaneous calcinosis cutis she had. Any diagnosis? Yes. So classical here you can see heliotropic rash and Gatron papules. So dermatomyositis. This is 9-year-old child. She had a fever for 4 to 6 weeks. She was taking antibiotics. She had some loss of hairs. She had pancytopenia, and she came with a, you can see ulcer over the nose, typically on the lip, and ulcer sitting over the palate. What is diagnosis? SLE, lupus. So ulcer over the non-healing ulcer over the nose, face, one should think, and pancytopenia, adolescent girl, one should think of a SLE. Coming to the last case, this child, 6-year child, had a fever for last 3 weeks. All investigations were zero, bacteriological investigation is normal. There was leukocytosis with polymorph predominant, with ESR high and CRP high. Rest tests were normal. This child used to get this type of rash when child used to get fever. That is evanescence rash. You can see here rash on the face. When the fever disappears, child used to be very fine and no fever. He was playing. In between fever, he used to be absolutely all right. Only during time of fever, he used to get rash. What is the diagnosis? SOGI. So after next 2 weeks, he developed joint swelling. So this was a SOGI. I think I will stop here. Thank you. Thank you very much.
Thank you for such a wonderful session with such beautiful pictorial representation. I request the chairpersons to please give their comments. I request Dr. Prashant Wagh sir to please felicitate Dr. Atul Kulkarni sir. May I now invite our very own Dr. Ramakant Patil sir from Nasik, the chairperson, Chief Organizing Chairperson of MAHAPEDICON 2022 on the dais to tabulate the timelines for investigations of a patient with fever. It is bad in practice to order for a CBC or an X-ray within hours of a child acquiring fever. We pediatricians need to show constraint on the extent of the tests to be run on a child with fever. Sir shall give deeper insight into this. I humbly invite you on the dais, sir.
After excellent batting by Virat Kohli and Surya Kumar Yadav, this is Dinesh Karthik for you. I wish my two friends who are chairperson and Dr. Prashant Wagh is having his birthday today. Wish him a very happy birthday. After Dr. Atul and Dr. Naresh spoke everything about fever. There is nothing left for the investigations of fever. It has been excellent deliberation by Atul and spot diagnosis. What justice we are going to do for timeline of fever investigations? So which fever need investigations? So fever which do not have localizing symptoms, fever which are not having any associated symptoms, which is not very obvious. If you have got follicular tonsillitis, sore throat, if you have got fever with pain in abdomen, blood and mucus, I don't think we need, if history is there, then investigations are needed. These are the timeline of investigations is needed when we are not having any localization or we get a stumbling block, then and then only we need investigations. And as in introduction, Dr. Jagruti has said about, she said about one sentence about CBC, and famous quote by our Mahaguru Bhishma Pitamaha, Dr. Ambedkar sir said, it is not a complete blood count. It is a most incomplete blood count. So my one of the friend who is MD medicine and his son got MD medicine from Nair Hospital, is both a physician, and he was just talking to me. I had a patient of 2 days fever, body ache, myalgia, and somehow some picture I was not ready to fit him in somewhere. And then his son said, Papa, why don't you send fever profile? So this is the situation, because as Ambedkar sir say that we are treating with numbers, we are treating with investigations. So if I am able to give the message that investigations have to be last, and it is the history, and then clinical examination, and probably will not need this timeline of investigations. So these fever profiles and all those things, as famous saying goes, when we should investigate, which cases will I investigate on day one? Because nowadays with more awareness or being only child or parents who are slightly overprotective also, and nuclear families, on day one of 99.8 fever, we are not sure whether to call it as a fever or not, but they come with the reports or they ask us the reports. So to come to the science, when day one of the fever, in which cases we are going to investigate? There is a fever in a 5 days old neonate with a decreased urine output, weight loss, received paracetamol drops and oral antibiotics. What investigations we should do? So this is what exactly being done. He had CBC, CRP, blood culture was sent and antibiotics were started. What is the error? This is a clear case of decreased urine output, weight loss, and child is active. So it is a dehydration fever. A fever in 20 days old neonate brought with high grade fever, and one of our colleague received paracetamol drops and oral antibiotics. And next day child came with the shrill cry and convulsion. So in neonates, it is very important. These are the patients on day one, fever. Even if you are sure dehydration fever, you need to observe them for 6 hours, 8 hours, unless until child is very active. These are the patients where on day one, we are probably going to investigate. So fever in neonates, we have to ask these histories, maternal infection, which is now rather than calling as chorioamnionitis, III, prolonged rupture of membrane, and all risk factors. I will not go into detail of that. So another case of day one of fever. 6 years boy has a fever of 103.4 degree fever with rigors without any localizing symptoms. Do we need to do investigations? If yes, what investigations we are going to do? So mostly there is no need. But if you feel that this patient is having 103 fever with rigors, only investigations you will like to do will be PS for MP, not CBC. It will be the most erratic. So day one investigations, if at all you are going to do in infants, if not beyond neonates, beyond 3 months, it will be urine examination. And in case of older children, it will be PS for MP. So these are the, how we are going to judge the cause of fever. So for this, important is that most important is the history. What our PG students nowadays called as a HOPI, what we used to call as origin, duration, and progress. And this is very important, how the fever started. What was the pattern, rhythmicity, progression on day 3 and day 4. whether if it is a gradually peaking and high at onset and declining. If it is a gradually peaking and day 3, day 4, child is not good, it is more likely to be a bacterial infection. It was very high at onset and interfebrile period is normal. These are the children we are not bothered or less likely to be worrying about them, and it is more likely to be viral infection. And this is localization which is going to occur. So these are the patients where we'll be sending investigations on day 3 and day 4, and then the investigations, what different investigations we are going to send. One more case I had, and that I have heard a similar case also in by Dr. Tushar Maniar, that a 5-month baby of fever for 10 days. And he said that there was a fever for 30 days. Child is to get 108 fever or 107 or 100.7 or 100.8 at 1 o'clock or 12:30 p.m. And that was going for 30 days. And similar case was there with me. And this was being done that for that neonatal jaundice, grandmother was keeping the baby in sun, and it was being continued for vitamin D. And it was, as Naresh has pointed it out, it was a hyperthermia and not the fever. So we have to ask the history, we have to see how is the baby in interfebrile period before jumping on or being a trigger happy for investigations. Now is the case which I say that how is on day 3 or day fever or day 4 of the fever. If child is all right on day 4, we are probably sure it is viral infection. On day 3, day 4, they're more likely to have localization of the symptoms, or we know what could be the anatomical site, what could be the etiological causes, and probably we will be doing investigation for confirming the diagnosis for rather than finding the needle in haystack. And the famous quote of misapproach by Dr. Ambedkar sir, we shouldn't be doing manage first, then investigate, and then ask for the signs and symptoms why you are not improving. So this child had no rash. What investigations we are going to do in this child? So probably now the role of CBC, what we say, the leukocyte are list information. What information we are going to get it from platelet? Whether we have got high platelet count, probably it will tell us that there is thrombocytosis. If it is a low platelet count, we know that we are dealing with some viral infection. Associated symptoms along with that, we have to know what is the epidemiology. Associated, if there is a pneumonia, fever, and we are not able to, if it is a flu season, we have to search for that, or we may give empirical along with antibiotic. So role of investigations is to identify the hidden infection, particularly in infants for urine culture. As it has been again said that the middle age dialysis at the age of 40 and 45 years is because of pyelonephritis missed by we pediatrician causing renal damage, and they have landed into dialysis at the age of 40 and 50 years. So identification of urine infection is very important. Second important finding which I have come across because of constipation has been occupying 30% OPD of gastroenterologists. We pediatrician, it is 3 to 4%, but in last 10 to 15 years, I have found that it is my 20% OPD is of constipation. And out of this, any fever which is unlocalized, even of day 3, day 4, recurrent fever in between the child is absolutely fine. And parents never ever come, at least in 90% cases, coming with the history of constipation. We have to always ask them the history of constipation. Still parents will say, no, he is going daily for the school, because child doesn't allow them to come in the toilet. And we have to keep that Bristol chart in our consulting room and show it to the child. And child many times points out what is the, and this causes many times bladder bowel problems. BBD, the bladder bowel dysfunction, and this stool infection, cystitis, and this recurrent urinary tract infection. Many times we search and we do not get, because whenever we collect urine, many times it is brought to the hospital after 4 hours, and then it is plated and we do not get anything. So for blood culture, if you keep it outside for maximum time, it will have increased yield. Urine culture as fresh as possible, as early as possible to be plated. So this urine examination, urine culture, and associated symptom identification is very important. So to come back to the timeline, day one, in only these 2-3 cases scenarios, and also in day one, only cases other than neonate and malarial, we will be investigating where we are already knowing immunocompromised. And the commonest immunocompromised host we are coming across patients who are on chemotherapy, patients who are on ALL, because fortunately we are not having congenital immunodeficiencies or HIV is on declining this thing. So these are the patients who will be investigating, and also on day 4, day 5, there will be proper localization, and then we will be investigating for common infections, particularly blood culture for Salmonella typhi. Vidal test has to be thrown out. Typhoid.im also is not to be done. So these are the cases, and if there is a proper localization, we have to investigate these patients or some associated symptom for dengue fever. Then we have to suspect for commonest disease in our countries like scrub typhus. This has to be identified if there is no proper localization. Sorry. Now, this is after 7 days. If there is a fever without focus, most of the viral infections are ruled out, and probably very few remain. These are bacterial infections like Salmonella typhi, brucellosis, and rickettsia. In addition to that, few viral infections are there, which can present even in second or third week. And this was a 4-year boy who had fever for 19 days, had rash for a day in initial 2 to 3 days, snoring and lymphadenopathy, and he had pseudomembranous tonsillitis. And his spleen was just palpable. What investigations we are likely to do in this case? So this case is more likely to be a fever, infective case. So which are the viral infections which are likely to persist beyond 2 weeks? And there are 2 viral infections which are commonly persisting, is the adenoviral infection and infectious mononucleosis. So any patient who is all right in between the fever, who has got snoring, I have come across at least many number of patients who are having just palpable splenomegaly, discrete lymphadenopathy, had history of rash and pseudomembranous tonsillitis. The patch membrane is seen on the tonsil. And in this patient, monospot is not available, but we send EBV VCA, Epstein-Barr virus viral capsid antibodies, IgG and IgM, rather than sending for PCR. And many times this IgM comes positive. And this here we have got diagnosis in our hand. We can definitely counsel these parents that this is it will take time. And many patients, those who are immunocompromised or parents are very, it is given in only Sarah Long's textbook that in immunocompromised or patients who are having severe symptoms in infectious mononucleus IV acyclovir works. But it should not be like that. If child is having good appetite, is all right in between the fever, I don't want to connote that use acyclovir for the Epstein-Barr virus infection or infectious mononucleosis. So in fever beyond 2 weeks, very few bacterial infections remain, and brucellosis, tuberculosis, sometimes fortunate patient with rickettsia, they can have. And we have heard a very good lecture today morning about pattern recognition in rheumatic conditions and inflammatory fevers. And what is most important teaching in fever beyond 2 weeks, whenever there is history of, go and sit with the patient again and ask first 4 days what was the course of the fever. And this 4 days initial picture will definitely tell you, and whether there is any new symptoms is there in fever. Presence of new symptoms, localization occurring after that, probably that will narrow down your investigations. And in cases of tuberculosis, I just wanted to take opportunity over here. Gone are the days of doing Mantoux test. It is with the symptoms, 4 cardinal symptoms of fever for 15 days, which is documented weight loss of 5%, or no weight gain for last 3 months with history of tuberculosis, and then you are doing X-ray chest, which is suggestive of tuberculosis, or otherwise other symptoms which suggest lymphadenopathy or gibbous or CNS symptoms, and the duration is more than 2 weeks. In such cases, you are going to do X-ray chest, and then if X-ray chest is only 3 findings are suggestive, that is, if you have they got hilar lymphadenopathy, which we call Ghon's focus. Along with that, if you have got miliary tuberculosis or fibrocavitary tuberculosis, these are the only 3 conditions which are suggestive of tuberculosis. And microbiological diagnosis is very important. You have to do gastric aspirate or induced sputum and search for the microbiological evidence by doing gene expert, and at least 2 reports effort should be there for induced sputum and gastric lavage. And when these are there done and still if it is negative, then you can have with the history clinically diagnosed tuberculosis, and then only you will be able to start anti-tuberculosis treatment, because it is an offense not to inform tuberculosis patient even if it is a clinically diagnosed tuberculosis by section 264. So if you are doing gastric aspirate or gene expert, then it gets automatically informed to government, because once if it is done free of charge, otherwise in out private you will require 2,000 to 2,200 rupees. So once this is informed and then you are clinically diagnosed tuberculosis, then you can start anti-tuberculosis treatment. If these patients again you are suspecting, then you have to do thorough like bronchoalveolar lavage. So higher centers to referred is not for the higher building, but it is where the additional things are available, a higher center like bronchoalveolar lavage, and this has to be sent for the culture simultaneously, because even ultranat is detecting 16 bacilli per this thing per ml, but culture immediate culture will detect nearly 10 bacilli per ml. And once this is detected, and for drug sensitivity, gene expert is giving you only upfront rifampicin sensitivity. But for you have got LPA1 and LPA2. LPA1 is giving you rifampicin and INH. So INH already, rifampicin you have got already the report. INH will be available by LPA1 and LPA2, because for doing this line probe assays, you require at least 10,000 bacilli per ml. So immediate culture is necessary for doing all these investigations. So to take home message about tuberculosis, every effort has to be made to do gastric aspirate for gene expert or induced sputum for the gene expert. And in timeline of investigations, it is newer symptoms and first 4 days behavior of the fever, which is important. And this is the diagram which shows that what are the causes of infectious causes of fever beyond 2 weeks in developed and developing countries. So we have got rickettsia and mycoplasma is not there in the developed countries. Lyme's disease is not in our country. Abscesses in our country is more. And again, brucellosis has been rickettsia. Brucellosis is the common cause in our country for fever beyond 2 weeks, which is rarely seen in the infrequently seen in the developed countries. Again, typhoid and all these conditions which are seen. Just to mention or complete, I have already the time is over, but these are the different rapid diagnostic tests which are already available commercially. Probably they will come, but we shouldn't be trigger happy in taking all these tests, because they are having turnaround time very slow, even up to 2 hours to 7 hours. Even identification is done in 2 hours and sensitivity is being given in 7 hours. Like rapid pathogen identification methods like PNA FISH, peptide nucleic acid fluorescence in situ. It identifies coagulase negative and coagulase positive staph, Klebsiella, Pseudomonas, and E. coli. Accelerate phenosystems. It detects 7 microorganisms in 2 hours in isolated and susceptibility in 7 hours. We are hearing biofire, and newer technique is going to be on rRNA and shotgun metagenomic sequencing. And probably it will give a diagnosis of many pathogens in very rapid time in 8 to 10 hours or 14 hours. So friends, most important is a carbapenem's rapid detection, which is very important for New Delhi Meteorologist and OXA. And these detections will be available, but this is only for the subspecialty people who are infectious diseases expert, those who are intensivists. For we commoners or for we generalists, it is the history and common investigations. If you do only urine examination, blood count for hemoglobin and platelet, eosinopenia, and if you are going to do urine analysis, urine culture properly collected, explain to the parents how the urine culture is being taken. And I have made it a policy for last 3-4 years, personally explaining to relatives of my patient how to urine culture to be collected. and it has definitely made a change in positivity of urine culture. This and doing a blood cultures on day 4, day 5, or if you are clinically suspecting Salmonella typhi. In 2 weeks, after 2 weeks, then you can justified in sending brucella and doing test for tuberculosis. These are our common patients, and if you are going to do only this for 90% times, you will be correct. 10% are for the subspecialty. They should also thrive. Thank you very much, friends, for your patient listening.
Thank you so much, sir, for such an enlightening session. I'm sure when to investigate a patient with fever is now clear to all of us. I request the chairpersons to give their expert comment on the talk.
Hello. Sir, initially it is always pleasure listening to sir. But what sir told that initially after Virat Kohli and Surya Kumar Yadav, sir, Dinesh Karthik came. But for me, I think he is MS Dhoni of Nasik IIP, and he was leading from the front. He conducted 3 days of extensive conference, and still he is giving this lecture. So hats off to him.
I now request the chairpersons to felicitate Dr. Ramakant Patil, sir. Also, I request Dr. Krishna Pawar ma'am to felicitate our chairpersons. For our next mixed bag session, I invite the chairpersons, Dr. Arun Gachare sir and Dr. Yogesh Papde sir to grace the stage. I also would like to invite the first speaker, Dr. Sandeep Patwardhan sir, to please come on the dais. What we had known as congenital dislocation of the hip is now rechristened as developmental dysplasia of the hip because it is more to do with the shape and size of the acetabulum of the femoral head, unlike a normal femoral head having slipped out from the normal acetabulum. Congenital talipoequinovarus, as the name suggests, is like a horse's foot, and it occurs normally in the 3rd trimester when the baby has insufficient room inside the uterus. How much of these two disorders self-correct or can be cured with just physiotherapy, and how many of them will go under the knife will be clarified today by Dr. Sandeep Patwardhan. So please.
Thank you, ma'am. Chairpersons, shall I start?
Yes, sir, please start.
Thank you. So as you saw, like after the Indian batting, it's Namibia now. So nobody watches Namibia play. So we have this session on surgical section, and I was told by Dr. Patil, Dr. Sharmila, and Praful Bhai to talk on what's new in DDH and CTV. And I thought that let me start by saying what's old. And what's old is the treatment pathways. If you see the treatment pathways in DDH, you will see that it's either complex open surgery in our country, simply because there is no early detection or surveillance. If we do early detection or surveillance, then we are likely to be able to treat it by simple methods of repositioning. This is what happens when DDH comes to us late in the walking age or even beyond walking age. You have to do really complex open reductions, femoral osteotomies, acetabular procedures. And ours is a country where you can have an 11-year-old girl come limping in your OPD and say that I've never been told that I have DDH. And she's still untreated. And she has to really undergo a really major surgery on the pelvic and the femoral bone, extensive cuts, and you can never guarantee them a good result at 11 years, though some might get lucky occasionally and have decent results. So this is how things need to be done, but this is not how things should be. What should be is early management by repositioning or at the most reduction. For repositioning surgery or reduction surgery, all that is needed is a simple splint. What it needs is a small cloth and strap brace called Paulik harness, where you position the baby in such a way that it guides the hip into flexion, abduction, and allows the kicking movement allows gentle reduction of the subluxated or dislocated hip with very, very low rates of avascular necrosis rather than forceful open reductions or surgery. It promotes acetabular development and is a very simple and effective tool to completely cure this disease. If the child is beyond 6 months or nearing walking age, probably we need reduction and a spica. So this is what is an closed reduction where I have done an arthrogram. You can see the die and you can see that the socket is empty. It is filled by fibrofatty tissue and the head is lying outside. But if you do a gentle reduction, I will be able to reposition the head back into the socket. You can see a very sharp rose thorn, which tells you that reduction is adequate. And then a plaster can suffice and we can completely avoid the surgical treatment. So this is an example of a right DDH being treated by a closed reduction and spica. And that is his hip development over 9 years. And you can see perfectly normal acetabulum and head formation as time goes by. So the key to good, effective non-surgical treatment is surveillance. And what's new is surveillance. Unfortunately, as pediatric orthopedic surgeons, we do not have access to the newborns or the babies. It is you people who have to do that job for us. So what's new today is what you should understand. Please detect DDH early, do an early referral and keep a good follow-up so that we know how the child could be saved from unnecessary or prolonged surgery. So the new things are in diagnosis in screening programs, understanding what are the clinical signs and judicious use of ultrasound. Neonatal hip screening program, why should we do it? When do we do it? How do we do it? The first thing is mental awareness. You must have a very high index of suspicion. When are you going to do a screening or refer for ultrasound? This is how the baby looks. He is telling you, am I at risk? Because DDH is a hidden anomaly. CTV is a visible anomaly. You can see it. So if you have a child who has torticollis, if he has plagiocephaly, if he has congenital hyperextension of the knee, if he has metatarsus adductus or a clubfoot, the first job is look at the hip. Before you do anything, you look at the hip because this is what you're going to miss otherwise. If you see subtle increase in the skin folds on the thigh like this or a shortening, you must pick it up because again, DDH is a painless condition. On examination, if you have extension looseness or restriction of abduction on one side, you're supposed to do what is known as the Ortolani test. Now, Ortolani's test as a screening test was given by Professor Ortolani, who is an Italian pediatrician. So it was not an orthopedic surgeon who described screening. It was a pediatrician. And Ortolani's test says that if you do a flexion abduction maneuver, you should hear a click or a clunk of reduction. And if you are able to feel this, then this child probably has developmental dysplasia. But not every hip may be completely dislocated or reducible at birth. Some of them may be unstable, which may go out and come in and may eventually dislocate at an older age. That is why the terminology changed from CDH to DDH. Not every hip is dislocated. It may be unstable or dysplastic. So what you do is you do a provocative maneuver. You adduct and try to push it behind. And if you feel a give way that the hip is going out, then you are probably looking at a dysplastic hip. But the pitfall is that it's very, very subjective. Everybody may not be trained or your fingers may not have that kind of memory that you can pick up. So in these situations, the remedy is to get a good ultrasound. If you suspect you have a high-risk baby with all those features, firstborn, breech, LSCS, female with looseness, then probably you can send for an ultrasound, which will show you the cartilaginous head and labrum. The ultrasound is very, very good because it shows you cartilage. It has a 3D direction orientation. It's dynamic, highly sensitive. It's safe, it gives you immediate results, it's very convenient, there is no radiation involved, and it's good for follow-up and treatment also in brace. You detect iatrogenic posterior dislocation also in the Paulich harness, and you can look at how the acetabulum is forming. So that is Professor Graf, who in 1970 has described. It's not at all new. But why is it new year? Why am I mentioning it? Because we still don't do it. And he said that better an ultrasound today than a limp tomorrow. And that was his courses which he conducted in India, and we learned from him. So he told us how to look at the pediatric or the neonatal hip rather, what are the structures to be seen, and you do it by the Graf method. What if I still don't want to do ultrasound or I don't know how to interpret it? You still can do plain X-rays. And when do you do X-rays? The recommendation is at 4 months to 14 months. So at 4 months, as early as 4 months, you can do that X-ray because the ossific nucleus, the dot of the head, is expected to form by then. And what you can do is draw lines from the center of the acetabulum and along that dot. And what you can see is that if the head is lying lateral, then it is likely to be subluxated. And if it is lying superolateral, it is dislocated. And early detection again will be very, very useful even on a plain X-ray. So with all this background, in 2022, we have formed the National DDH Screening Guidelines, and we are fortunate that the IAP has been part of this project. As Secretary of Pediatric Society of India, POSI, IAP, Indian Radiological Imaging Association, Indian Federation of Ultrasound, gynecologists, FOXY, and IOA. We did an extensive literature survey following the Delphi approach, and we have made a program which I hope everybody, all pediatricians will use, and we have tied it up with your universal immunization program. So this is what we have given in your brochure. You have I think a booklet which has been given to all of you. We have published it and printed it as to how to approach at your vaccination screening in a neonate, what to look for, when to order an ultrasound, when to do X-ray, and how can you screen for DDH. Some minimal tests which should be done, at what age should you do them, and when should you order X-rays. And very, very simply, we have made some charts. So we hope that like we eradicated polio, hopefully with early detection and neonatal screening, we'll be able to bring down the incidence of surgically treated DDH. And most of them can be picked up early and just repositioned or reduced. So these are the minimum investigations. So to move on from the DDH to the CTEV, CTEV is very obvious. It's seen at birth. What is new is antenatal diagnosis. Every month, I see at least 2 mothers with an ultrasound report saying that my baby has been diagnosed with DDH. What do I do? Shall I terminate? And what will be the life of my baby? So what's new for us is antenatal counseling, which is very difficult for an orthopedic surgeon. Okay, talking to patients, explaining to the mothers patiently. When that happens, more and more preparedness of the mind helps early treatment, because counseling really, really matters. Correction is again conservative with plasters, avoiding surgery. What is important is retention. Once the clubfoot is corrected, we need to find ways of making that child wear the brace so that it does not relapse. Social awareness programs again are important, and that is what is new, and that is happening through NGOs and various organizations, and how to manage relapses in case the children don't wear braces. So traditional ultrasound diagnosis and counseling is still the cornerstone, where if you see an ultrasound showing a clubfoot like this, but what is new is now 3D scans. So I have some really nice scans which patients have come up with. And this is also, it helps us explain to the parents in a much better way that this is clubfoot and how it can be treated. The second thing that is new is that the traditional dogma was it is best to start casting as soon as possible after birth, right? So in fact, Ponseti in his manual said that if the child has breach and he has clubfoot, before the head comes out, start plaster. So that was a highly extreme view, but that is what he meant, that when the collagen is immature, if you start early plasters, you're likely to get better results. But we have now found and published reports are saying that allowing adequate time for parental education to cope with the whole situation can positively affect the treatment outcome. So a delay of few weeks, 3 to 4 weeks, is not harmful. You can still do plaster treatment and results are no different. So you don't have to rush them into trying to do something. Give them time to understand that this is what it is and this is what is going to happen and how we go about it. You can offer them literature, visit the Ponseti International website, understand more about the disease, etc. But on the ultrasound, for the radiologist, I have some red flags because a lot of clubfoots have actually some other disease. If the tibial length is short, we probably are looking at hemimelia. That means absent distal tibia, and that is why the foot is inturned. If you miss that and say this is clubfoot, the prognosis is completely different. And it's really a terrible thing to treat a hemimelia. If you have multiple contractures with reduced fetal movements, you're looking at arthrogryposis. An arthrogrypotic child with clubfoot is totally different ballgame. That doesn't behave as well as a simple clubfoot. If there are spinal defects or neural dysraphism, then again the clubfoot is a paralytic clubfoot, and that is a different ballgame altogether. And amniotic bands. So I'll just show you some examples. Now, if you have a clubfoot born with these kind of syndromes, you can't offer them a rosy picture. They have a terrible prognosis and multiple surgeries may be needed to treat these conditions, which are otherwise labeled as simple clubfoot on ultrasound. So this is totally different. So this is looking like a clubfoot, but it's tibial hemimelia. You can see divergence and shortening of tibia, absent distal ankle completely. Ponseti method still remains the gold standard. We do plasters, and he studied the anatomy and told us that essentially the genes responsible for clubfoot become active in the 12th to 20th week of intrauterine fetal life. The collagen tissue has something like a myofibroblast, which pulls the foot into a deformed position. And these remain active to about 4 years of age, which is why he says bracing must go to 4 years. If you say that corrections, don't wear braces, they will relapse. Okay, so there's excessive collagen synthesis, which may persist till about 4 years. Easy treatment by plasters on an outpatient basis, simple plaster technique. But what is important is the brace. To put the child in a brace for about 4 years is a challenge. And most of the times the relapses are because of lack of brace wear. So the new thing is having good braces. So what's new is customized, comfortable splints, which are better made with now 3D printing technology, adjustable straps, and making the child more comfortable and the parents more compliant. So we are having 3D printed fiber braces. We are trying to get rid of that bar in between so that the child becomes more compliant. But retention of the clubfoot correction is equally important as to getting the child corrected. Awareness by social programs, icons like John Abraham are getting involved. We have the World Clubfoot Day and we have group therapy. We have all the babies lined up in the clubfoot clinic so that they can share notes and we can have a more effective way of managing them. Relapses, like the last point I said was relapses and complex club feet. For neglected feet, syndromic feet, we have streeters like this. We have something called as a fixator. This is an indigenous tissue distraction device developed by Dr. B.B. Joshi from Mumbai, and good for kids where we can actually distract the tissues and add length and get good correction. This is an example of a stiff foot which was operated multiple times, and just a fixator without any open surgery and soft tissue distraction. That is his correction at 4 weeks, and that's the function at 1 year. 3-year-old untreated clubfoot, again, instead of doing open surgery, a fixator assisted surgery, and that's the child at 4 years walking pretty well. To summarize, I think what's new is awareness. What's important is surveillance. What is important is early diagnosis. What's important is patience and counseling and early intervention for minimal surgery and good outcomes. Thank you very much.
Presentation, and you have properly mentioned each and everything and also given proper take home message. Thank you, sir, very much.
Thank you for such a
Plaster for CTV? How early? First week is ideal, but third week is also not bad. Manipulation by the parents does not hold it. When you do manipulation, it has to follow the Ponseti method of reducing the talonavicular joint in a particular sequence. But once you manipulate and get it reduced, it has to be held. If you use paper tapes or sticking plasters, it forces into a wrong biomechanical angle, which causes more relapses like eversion. Eversion is to be avoided. What we need is abduction. So just manipulation is not good. If you have positional club foot, which means it's a completely correctable club foot, or if you have a calcaneovalgus foot, then only manipulation. They don't need any plaster. So that has to be assessed, how supple or how stiff it is by some scores.
Thank you for such a wonderful session, sir. I request Dr. Arun Gachai, sir, to felicitate Dr. Sandeep Patwardhan, sir. I now humbly invite our next speaker, Dr. Bhushan Pustake, sir, on the dais. Half a year through, and that is when the actual problem begins, or should I say, the actual dental problem begins. It is stressful not just for them, but for everybody around them. Teething problems in babies usually start at ages of 6 months and can go up to 2 years. The baby is cranky because of the teeth, because the teeth are coming in, parents are irritable, and everything is chaotic. Myths like application of honey, pacifier does not work, or does it? To solve all the teething problems in children, we have with us today Dr. Bhushan Pustake, sir. So please.
Very good afternoon to everyone present here. The topic for my presentation today is teething troubles, or we can take it as dental troubles, which we get to see every day in pediatricians clinics as well as the dental clinics. The contents of my presentation are: the first, brief information about dental caries, the biggest problem that the children face worldwide. So brief information about it. Then pediatricians' unique position or status for prevention of dental caries and early intervention. Third is treatment options and the preventive measures available. And fourth is a few minor clinical situations that we come across every day. Early childhood dental caries, as the name suggests, is presence of even a single carious tooth in a child who is less than 6 years. If it is seen in children who are younger than 3 years, it is known as a severe form of early childhood dental caries. It can start right at the age of 8 months, 10 months, 12 months babies. And such babies can come to us with these kind of white or yellowish discolorations. So the dental carious lesions can present themselves as these yellowish or brownish discolorations. Initial cavitations are white lesions like this. And if we ignore these lesions, they can be transformed into destroyed teeth surfaces like this. Even if we delay the diagnosis and treatment, the teeth get destroyed to an extent where it not only looks ugly, but makes the child symptomatic and teeth non-functional. In fact, many a times the parents and the children, rather the parents come to you or come to us with a complaint that हे दात असेच आले, येतानाच असे आले, खुरटले गेले, किंवा आम्ही खूप लक्ष देत होतो पण ते आपोआप असं झालं. So these are the commonest representations by the parents. We should identify this as a disease and not mere external staining of the teeth. If ignored, the dental cavitations can lead to formation of abscesses, cellulitis, and at times cystic transformations within mandible or maxilla. Now, is it really relevant to us in India? As per the only official survey by the government of India, In 2002-2003 National Oral Health Survey, it reveals that more than 50% children in India are suffering from dental cavities or dental caries. A systematic review with meta-analysis published in 2018 also confirms the same prevalence of dental cavities to an extent of 50%. That means every alternate child in India is suffering from dental cavities or dental caries, and which is in fact a preventable disease. As Dr. Sandeep Patwardhan pointed, that early identification and early referrals probably will solve the problem to quite an extent. Same applies with dental cavities. Worldwide also, dental caries remains a disease which is much more common than asthma or hay fever. Now, why do we need to know about dental cavities? The consequences of delayed diagnosis or delayed treatment, for which the patients come to you as well as us, are varied. The first is pain, severe pain to an extent that the child is not able to sleep or eat for days together. Pain or irritability, and that leads to disturbed sleep. Secondly, the child is it becomes difficult for that child to eat or enjoy food, which leads to nutritional deficiencies and failure to thrive or lack of weight gain for over a period of time. Then frequent upper respiratory tract infections or fever, which are considered to be of unknown origin. Dental cavitations are associated with streptococci, and that is one probable reason that the children suffer from recurrent respiratory infections or fever. Permanent teeth damage. The best predictor for cavitations in permanent teeth is the incidence of carious lesions in primary dentition. So if we want the permanent teeth to be in place in a healthy manner, the primary dentition needs to remain healthy. Not to forget about expenses. Delayed treatment leads to expensive treatment. And it puts not only a physical burden on the parents as well as, but it puts the financial burden on the parents if we delay the diagnosis and treatment. If the child has multiple teeth with cavities, multiple appointments are required. So loss of work, loss of school days is one consequence, and loss of work for the parents as well, not only for the child. What are the causes of early childhood dental caries? This might be a contentious issue because pediatricians advise breastfeeding up to the age of 2 years. But as per the references, breastfeeding or bottle feeding at will or extended beyond the age of 12 to 15 months can lead, rather, this is the most common cause of dental cavities occurring in children. Additional factors are sugar addition in the diet, lack of awareness about cleaning teeth, and the poor oral or dental hygiene of the parents. So all these factors lead to earlier dental cavitations in children. The pediatricians have the unique position where they can help prevent this problem at an earlier age because they get to see the patients at the earlier age. What pediatricians can do is, first thing, the first dental visit of the children should be at the age of 6 months and not beyond 1 year of life, first birthday of the life. And simultaneously, the pediatricians can guide the parents about oral hygiene maintenance, feeding and dietary instructions, and examination, early examination. So cleaning of the teeth should start as soon as the child is born. After every feed, the gum pads, the tongue, the cheek mucosa should be cleaned with the help of a wet cloth or a wet gauze piece. After the eruption of teeth, any age appropriate brush, finger brush or baby brush or junior brush should be used, along with a toothpaste after 1 year of age. It has to be a low fluoride containing toothpaste. How much toothpaste should be used? A smear layer for the children under the age of 3 years and a peanut sized toothpaste for the children between 3 to 6 years. The low fluoride pastes which are available are Cheerio Gel, Pits Bunny, Pediflor, Kidodent, Colgate Strawberry, Bubble Fruit, Spider-Man, Barbie. All of them are low fluoride containing toothpastes. They are safe and they are recommended in a country where no fluoridation of water is done by the government authorities. What should be the feeding instructions? Encourage solid food as soon as possible after the eruption of teeth, and discourage feeding at night beyond the age of 12 to 15 months. Simultaneously, reduce the sugar in diet and separate utensils for the child. The utensils or spoons should not be shared with the child. That is one thing which can prevent the earlier infection from the parents to the child. A common diagnostic procedure that can be used by all the pediatricians is lift the lip approach. Whenever the child is coming to you, lift the lip, and in case of any discoloration found, refer the child for the intervention. Any discoloration is a pathology. No, there is no physiological discoloration of the teeth. If the pediatricians or the dentists find these kind of cavitations, they can receive proper treatment in the form of a cosmetic rehabilitation of those teeth. So here are the examples of cosmetic rehabilitation of teeth. Teeth with completely destroyed structure and the teeth with rehabilitation by restorations. So the children can receive, this is pre-treatment photograph, this is post-treatment photograph. So they can receive as beautiful treatments for themselves as any adult can receive. Unfortunately, at times we might have to take out all the teeth just because they are not restorable and the patient reported quite late to us. There are two beautiful preventive measures available, but which are very less used in our country. The tooth can have cavities on two surfaces. One is the chewing surface and the other part is non-chewing surface. The chewing surface has developmental fissures. These developmental fissures can be blocked or sealed by the use of spit and fissure sealants, which can prevent cavities on the chewing surface, while periodic fluoride application can be done to prevent the cavitations in the non-chewing surface. But I repeat that the sealants are one-time procedures. The fluoride application is a periodic procedure. We have to repeat that. And along with, if we are prescribing fluoride containing toothpastes, that will surely help reduction in the dental cavities, because primarily the milk teeth have cavities on non-chewing surface. A few other clinical situations which we come across on daily basis. A natal or neonatal tooth. Ideally, the tooth should be retained, but it needs extraction only and only if it is causing ulcerations on tongue or it is causing difficulty to the mother for feeding. And the most important part, if the tooth is extremely mobile where it can be displaced and aspirated. Now, why does this happen? Because the normal tooth has this big root to support itself. The neonatal or natal tooth does not have the root, and that is the reason why with slightest of push, it can be displaced and aspirated. That is the reason why if it falls in these three conditions, we have to extract the tooth in a hospital setup. In case of a traumatic injury, any tooth which has been knocked out can be reimplanted if the procedure is done immediately. So immediate referral is something that can save the primary or permanent tooth, and even such fractured teeth can be replaced, or the same fragment can be reattached if the child is sent in time to a dentist. Another situation which we all come across very frequently is double teeth, for which the pediatricians are consulted. The thumb rule: if such double teeth are seen and if the primary teeth are mobile, just wait and watch. If those are firm, then the removal or extraction of such teeth should be done. Situations where only reassurance to the parents and or symptomatic approach is indicated. These are three situations. First is spacing between the teeth. एक मराठीत गाणं आहे, एका तळ्यात होती बदके पिले सुरेख. It means that the child can look ugly. In pediatric dentistry, the stage is called ugly duckling stage. Child might look odd because of the spacings present or because of the bigger size, but believe me that this is physiological. It does not need any treatment, and the child gets a normal dentition if we just wait and watch. If there is some mass on the erupting tooth, a symptomatic treatment can be done in the form of topical anesthetic gel or SOS paracetamol. And non-eruption or delayed eruption of teeth is one complaint. Routinely in Indian context, 4 to 18 months is the time for the first tooth eruption. And permanent teeth also, if they don't erupt, it does not mean that there is some problem. The teeth can develop only after their development is completed. Now, this was the clinical situations. There is one objection taken against all the pediatric dentists that we take too much of time to treat. But the fact is that we want to offer an enjoyable dental experience to the child. We believe that no matter how good we are at operative dentistry, but the appointment will be a failure if the child departs in tears. And that's the reason why we treat the children in a systematic manner. So this is how we treat the children. It is a scientific manner in which we call the children, make them comfortable in our setups. Do not start the treatment right away. This is called as behavior guidance. We spend some time with the children to talk to them, to make them comfortable, to identify their fears. We can always slap the child and get the treatment completed in one sitting, but that cannot offer a pleasant experience to the child. So this is what we follow. Maybe a couple of appointments are spared only to make the child comfortable. They receive small gifts as a matter of appreciation. Then we start with smaller procedures, which are non-fear provoking procedures. Like, tell them about the procedures, show them how the procedures are, like what the instruments are. So this is step 2. Simultaneously, we ask other children to watch their treatment. So I'll just run through the video. That's all. When one child is being treated, other children can watch their treatment so as to get a rough idea that we do not harm them and we are not as dreadful as we appear. For every positive behavior, the behavior of the child is appreciated in the form of some gift or maybe putting a star on the child's hand and so on. Once these small procedures are done, even the procedures like radiographs are also well informed and then executed. Nothing is done in a hurry or without informing the children. Once we are through with these stages, the children are able to cooperate for the procedures like local anesthesia with eyes open and in front of the parents without the need of any sedation or general anesthesia. Once this procedure is completed, the children are able to cooperate to an extent where we can give blocks, inferior alveolar nerve blocks or posterior superior alveolar nerve blocks, and extract 2, 3, 4, 5 teeth at a stretch without a single tear in the child's eyes. This is what we want to complete, and this is how we want to complete the treatment. But for this, it really requires the parents, the patient, and all of us to spend a decent amount of time to make the treatment physically as well as emotionally an enjoyable dental experience. So to conclude, for all of us, is cleaning the gum pads, the teeth right from day one with the help of a wet cloth, low fluoride toothpaste to be used for the children after 1 year of age, first dental visit on the first tooth eruption and no later than first birthday of the child, lift the lip at the time of every examination. Please include it in your day-to-day examination pattern and refer if any discoloration is seen. And lastly, dental cavities need management. Only fillings or restorations is not the treatment. The modifications in diet oral hygiene maintenance habits, use of preventive measures like sealants and fluorides, and the fillings will help to control the menace called as dental caries. Thank you very much for the patient hearing. Yes, sir. So low fluoride are below 500 parts per million. That means around 0.5 milligram of toothpaste is available in 1 gram of toothpaste. Considering that the child will ingest the entire amount, it amounts to active fluoride to the extent of 0.3 milligram. The daily dose is 1 milligram for all of us. 0.3 milligram is not going to cause any problem. The probable toxic dose is to the extent of 8 to 16 milligrams per kilogram body weight. So for a probable toxic dose, the child will have to gulp down the complete toothpaste and not less than 60 grams of the toothpaste, which is practically impossible. And that's the reason I mentioned that these all are safe and recommended. For adults, we can use 1000 ppm of toothpastes. And that's the reason why those toothpastes, which I mentioned, they contain around 480 ppm of toothpaste as per the rules and regulations. Yes. Ma'am, nitrous oxide anesthesia, I am not the expert. That should be asked to the pediatricians, the anesthetists. Many dentists are using, but I think that question should be answered by the anesthetists. Yes. Sir.
Yeah, thank you. Thank you, everyone. I'm the anesthetist, and I just casually came to for this lecture, and I'm getting an opportunity to answer the question. I feel that we should not give nitrous oxide in the outpatient clinic or anything, because there should be the resuscitation equipment and other things available.
I was sitting next to the right person. Actually, few of my friends are using
I think
periodontists.
we should
are using.
always ask the anesthetists about this question, because it is a point of contention in the field of pediatric dentistry currently.
Whenever patient comes, yes, we used to give the prescription of calcium preparations. And another question is, what is your means? Many a times relatives correlate everything with the teething problems like fever, diarrhea.
Yes, sir. Let me tell you that dental caries is not a disease caused by deficiency of calcium. Dental caries is a disease of civilization. Processed food, consumption, overconsumption of sugar, and extended milk that gets pooled around teeth are the reasons for dental caries. If the teeth have hypoplasia or hypomineralization, in a few cases, it is a clinical situation. Only in that case, calcium supplements will help. But by and large, dental caries cannot be cured by supplements of calcium and vitamin D. It can be an adjunct to the preventive protocol. And secondly, everything related to teething. Teething can make the children restless. It can make them consume more liquid than solid food. So maybe the child can keep on crying for a day, for a few days. That's all can happen with teething. There are no more complications of teething as such.
What about the type of toothbrush and cloth and so-called dental
Yes. Any soft toothbrush of good brand should be used. And I have used the word age appropriate size. So if the parents are able to reach out to the last tooth with the available brush, that can be used. But the science tells us to make use of only soft toothbrush of age appropriate size. About dental floss, dental flossing, although it's a good technique, but very difficult for us to follow in case of children. The adults can do flossing for themselves, but for children, the parents have to do it. Uh, uh, Periodic fluoride application and use of fluoride containing toothpaste is a better option to prevent the cavities in the interproximal areas. So if we are using them, there are less chances that the proximal cavitations can occur. And if, as I have shown, if the child has spaced dentition, there are great chances that only gargling or brushing will remove the food debris between the teeth. Flossing is done to prevent the food lodged in between those teeth. Flossing, if we wish, can be done with the help of Colgate or Oral-B dental floss, which is available. And that too, ideally, it should be done after every meal. But practically, we can do it at least once a day. Yes.
Last question.
If you see the age of the epilepsy patients, have many kids who have got their first dose after 1 year. So anything we, I know it's normal, but anything we refer them for any delayed eruption or maybe that causes a lot of parental anxiety.
Yes. So that's what I had included it in the presentation, that this is a normal variation to see the first tooth eruption by the age of 18 months, at least in the Indian context. And looking at the trend of dental cavities over a period of last 20 years, it is a boon in disguise to have the teeth at a later age, because the children who get teeth at the 4 months of age and 6 months of age are the children who get dental cavities, for which they have to undergo extractions and root canals. So I would say that it is a boon in disguise to have the teeth at later stage, and there is no abnormality as such associated with this. It's a normal variation.
एक मिनिट मॅडम. सर आजकाल काही कंपन्या काही जेल्स प्रमोट करतात 5-6 महिन्यानंतर वापरण्यासाठी, दात येतात म्हणून तुम्ही लावा म्हणतात, त्याच्यावर काही इनलाइट केलं चांगलं. जेल्स असतात, फॉर एक्झाम्पल ऍस्ट्रम कंपनीचं गमीज म्हणून एक जेल येतं, अजून 2-3 कंपन्यांचं आलं, तर ते आम्हाला काही लक्षात येत नाही, तर ते खरोखर प्रमोट करावं की नाही करावं.
As such, these gels, they do not play any role in early teething or healthy teething. So it is up to the consultant whether to use it or not, but scientifically it is not justified or not recommended. The gels are recommended, topical anesthetic gel and topical antibacterial gels. And topical antibacterial is chlorhexidine, which is used or which can be used intraorally. It can be done in cases where gingivitis is seen. And topical anesthetic gel, maybe benzocaine or lignocaine. The commonest is benzocaine, topical benzocaine, which is of most use. It can be used in cases where multiple ulcerations are seen intraorally. So these two medications can be used and should be used in pediatric dental patients. No other gels as such have any role in making the dentition or the gums healthy.
Thank you, sir, for such an interesting session. And also the video at the end was so beautiful. I could see everyone smile. I request Dr. Arun Gachade, sir, to please felicitate Dr. Bhushan Pustake, sir. For our next session, I humbly invite Dr. Neeta Ghate, ma'am, on the dais. The millennials born in the last decade of the past century have had a premature exposure to many things in life than ever before. Screens, gadgets, modern modes of transport seem to be lesser evils as compared to these teenagers turning over to substance abuse, especially in homes where either or both parents or grandparents indulge in smoking or drinking. Vaping is the most recent entrant in tobacco use, although smoking tobacco is not very uncommon. Dr. Neeta Ghate, ma'am, will guide us. How shall we guide first the parents and then the children? Madam, please.
Thank you very much.
Nasik branch and MAHAPEDICON organizers for giving me this opportunity to present our humble effort. I can move the slides. Adolescents, as we all know, is the largest population in India with about 253 million adolescents, and we have the demographic dividend. That means we need to invest in the good health of adolescents so that the country benefits, and they are the future of the country. However, adolescent health challenges are much greater today than they were 25 years ago. And as foundation is laid for health in later life, a case for comprehensive and integrated investment in adolescent health assumes an urgency as never before. One such preventable risk factor for all the NCDs is tobacco use, and we need to prevent initiation of tobacco use in adolescents. NCDs, as we all know, non-communicable diseases are cardiovascular disease, chronic respiratory diseases, diabetes, and cancers. Most importantly, most of these NCDs in developed countries are occurring above 55 years age. However, in India, they are seen in a younger age group, that is above 45 years age. And this means we've been having a loss of nearly 4 million health losses attributable to diabetes, cardiovascular disease, and respiratory diseases, which are some of the largest health losses in the world. And this means we need to start addressing the risk factors, one being tobacco use, and we need to prevent tobacco use starting, and the most susceptible age group for this is adolescents. As an ENT surgeon, I can't but help talk about oral cancers, which we are seeing. And in the last few decades, these are being seen in the younger and younger age group. And presently, they are seeing in less than 40 years age. This means that tobacco use is starting early, and we need to start tobacco prevention programs much earlier. In India, tobacco use is a very complex problem. Many times it's, if anyone uses mishri or uses a tobacco containing pan, no one feels it's odd. Predominant form of use is smokeless tobacco. There is a lot of societal acceptance towards it, and people are not aware that is harmful, and children see this and again start this habit. Most of the government school health checkups have regular health checkups, vaccination, nutrition, but there is no school-based tobacco hazards awareness program considering the Indian scenario. There are numerous types of tobacco used, and broadly we can classify them as smoking and smokeless tobacco products. Smokeless includes tobacco with suna, then tobacco containing pan, mishri. The India accounts for 70% of the global smokeless tobacco disease burden. And most of these products are sold after processing, mixing additives, scents, sweeteners or flavorings, which make these products palatable and pleasant for consumption, especially for the young minors. The sad part is this can be hidden from the elders. The child experiments with tobacco use, and because of the high addiction potential of nicotine, he becomes an addict before he knows it also. Smoking, it is banned. Other people come to know if the child is smoking. So at least there is some fear of elders and the child may not initiate it. But smoking also, we need to know that there are more than 5,300 compounds which have been identified. Nicotine is the addictive substance, and there are more than 70 carcinogens, including tobacco-specific nitrosamines. And there are newer, a lot of more temptations to students, to children, which are hookah parlors have mushroomed up. Luckily, Government of India has banned the ends, that is e-cigarettes or vaping, electronic nicotine delivery systems, but their illicit use is sometimes still noted. We need to understand that smokeless tobacco products, they have, when alkaline agents are added to them, such as tsuna or kat, which is katechu, the amount of free nicotine available is increased. And as a result, the smokeless tobacco, it is as addictive as a cigarette which is smoked, and there is lack of awareness of this. And many times areca nut, supari is added to it, and which has additional carcinogenic potential. So the harm is compounded when the person is using tobacco with areca nut. We can understand the burden of smokeless tobacco use, where there is almost twice the number of people are using smokeless tobacco compared to smoking. The Global Youth Tobacco Survey, the latest round which was released, shows 8.5% students are using tobacco. First time in India, the state-wise tobacco use has been studied, and there is a lot of regional variation also has been noted.
I'd like to share our humble experience about a school-based tobacco hazards program, which we've been doing since 2014. I was earlier a member of a NGO which was doing awareness for tobacco, alcohol, and substance abuse. I single-handedly started the tobacco modified program for tobacco awareness for adolescent school students of 8 to 10 standard. And later I was joined with another volunteer, and we conducted up to the onset of the pandemic about 15,000 students we were able to do this program for. We used some innovative approaches also. We held a drawing competition in one of the schools 6 months after the program was conducted. And we gave this as a home assignment on a weekend, so that again the tobacco hazards message is disseminated to the child's family members, his friends, his neighbors, so that again a reinforcement of awareness of smokeless tobacco hazards can occur. I also wrote a play for Ganpati, the no tobacco is, no smoking is stylish, which the 10th standard students acted out, so that again the message could be disseminated in the local area population. We have published the initial results in rural and urban areas, and it's in the Indian Journal of Pediatrics only. Because of the pandemic, we founded specifically a tobacco awareness group, that is Association for Tobacco Use Hazards Awareness and Preventive Measures. They're all my batchmates from BJ Medical College and our Pratinidhi madam, and there's another general practitioner from Kurla. So what was the effect of the corona pandemic on tobacco use in children? Corona pandemic, there was closure of the schools. The children could have, because of the free time available, it is possible that the children could have experimented with tobacco use more during these times. Also, it is possible that the cinema halls were closed, a lot of OTT exposure viewing was done, and many of the regional OTT films may not be carrying the mandatory statutory warnings which are usually seen in cinema halls. So this could have led to increased experimentation of tobacco by the students also. Also, it is possible that those who are using, considering the harm caused by tobacco in the COVID and the smoking, many may have wanted to quit also. We use this period to develop tobacco hazards awareness material in considering the Indian scenario. Most of the programs which have been done in the Western countries are about smoking hazards. There's not much awareness about the smokeless tobacco hazards. Mishri is also harmful. People are not aware of it. So we did a lot of research, and we developed material in the Indian context. And in view of Azadi Ka Amrit Mahotsav, we did a offline program in various schools in Kurla, Mumbai for 7,500 students. We also did an online program for 15,000 students of municipal schools. During this program, we used an audiovisual format. We explain what is addiction. We share our experiences of tobacco hazards. This is a national tobacco free quit line number, which we tell the children in case anyone they know is using it, any family member, or if the child is using it, he can avail of these free services. There is a M-servicization initiative. These are all initiatives of the government of India under National Tobacco Control Program. So if a missed call is given on this number, 011-229-01701, a text message is received where tobacco cessation advice is given to the person. During the program, we insist that the child should refuse tobacco how much ever anyone insists, at whatever stage in his life, in school, when they are going to college, when they are going for a job. And we tell them that they must always remain proud to be tobacco free. A special focus we did was on standard 10 students, because they may be leaving school to join college, where again they can be subjected to peer pressure and may experiment tobacco or other substance abuse. We are using, we have undertaken this research project. We've got the ethical committee clearance, and now in the process of data collection to assess the teachers' response towards the training material which we have developed to give tobacco hazards awareness information to school students. We did this online program for 15,000 students simultaneously of 249 schools of Municipal Corporation of Mumbai for standard 10. And this was done on 18th of August, and we did it online. The complete program was online. We were provided a Zoom link. The education department officials conducted from their office. We did it from our hospital, and we gave this information simultaneously, and the children attended it virtually in the digital classrooms. those 90% of the schools are in the morning session. So they attended with their class teachers, with the principals in the schools. And the rest of the 10% of the afternoon session attended it on the tablet pieces which the government had provided to them. And this ensured that the YouTube live streaming was there. There was also YouTube video which was put up on the education department website. And we did an analysis of the feedback of the teachers who attended this program to know whether this initiative was useful. So 98% of we got responses from 51 teachers, and 98% of the teachers felt that this program could prevent the students from experimenting with tobacco use. And the online format was found to be useful by 92% of the teachers. And the rating of the program was good by 60% and very good by 37%. And only 1% said that it could be improved. So online, the importance of school-based programs is experience of Western countries has shown that they are uniformly successful. Children spend about 8 hours of their day, that is 1/3 of their waking time in school, and they are maximum subject to peer pressure where they can initiate tobacco use in schools. So if at the school level, we can give them a tobacco awareness message, it's likely to be useful because all the students are attending it together and they may not force each other to experiment with tobacco use. There are very few reports from India, and there are very few evaluation reports. One such project, Maitri, mobilizing youth for tobacco-related initiatives, it was able to reduce the smoking prevalence, but not smokeless tobacco prevalence. So advantage of our initiative, we feel, is we are creating, it is developed in the Indian context, and it will help to create awareness about smoking and smokeless tobacco use. The benefit would be, while the awareness is created, the children will refrain from tobacco use. If they are using, they may contemplate quitting. And most importantly, children can be messengers of anti-tobacco message. And this is of vital importance to women smokeless tobacco users, many of whom, almost in India, we have about 90 million women who are using smokeless tobacco. Added to this is about 9 to 10 million who are engaged in tobacco farming or tobacco related occupations. Excuse me. Many of these are manual laborers, illiterate, women from rural areas or urban slums to whom the smokeless tobacco hazards awareness message is not reaching. So children can be a conduit through which this message can reach them. The online initiative was planned simultaneously for 15,000 students of Standard 10 from 249 secondary schools of Municipal Corporation of Greater Bombay. To our knowledge, this is probably the first such initiative in India post-pandemic. The advantages of the online initiative are it's cost effective, manpower time of health professionals can be reduced. There are numerous existing initiatives of the government of India to to tackle the tobacco disease burden, which include 85% pictorial warning, raised taxes. The Cigarette and Other Tobacco Products Act implementation, Section 6A and B, are sections which ensure no sale of tobacco to minors and no sale of tobacco near educational institutions. Implementation of this is very, very essential to protect adolescents from taking up tobacco. Our initiative can be a complement to the existing measures. The online program which we did was completely all implementation planning, everything was done online. The education department received, we contacted the additional commissioner of BMC. He was appreciative of the importance of this program. He contacted the joint commissioner of education department. He realized the urgency of it and he instructed the education department officials. A circular was issued by email, it was sent. We were sent a copy on WhatsApp. The program implementation was totally online. Through the digital classrooms and via YouTube live streaming. The feedback was also online because we sent the questionnaire to the education commissioner and through his ID it went to the teachers. Complete anonymity, confidentiality of the respondents was maintained as we had no contact with them. The program questionnaires were from the ethically committee approved offline project which we were doing, and only a few more added questions for the online program were included. So we feel that school-based tobacco hazards awareness initiative, creating awareness about smoking and smokeless tobacco, needs consideration for systematic nationwide dissemination. This can serve as a role model for other countries of Southeast Asia, where SLT use is also seen in addition to smoking. Online program offers a promising method of delivery of school-based tobacco prevention. This is an initial study of online, and we know that booster sessions may be needed later on. And in the future academic years, we do need to plan that. We weren't able to assess the students' feedback because it was a 10 standard, and they would be going for board exam. And the school was, and the education department was more interested in catching up with the learning deficit which occurred because of the pandemic. So in the limited time which was available, we were able to do our online program where that was also felt to be essential. So we all together must ensure that every adolescent in every school must be educated to the health risk and addictive nature of tobacco usage. I'd like to thank the Additional Municipal Commissioner of Western Suburbs, Sri Sanjeev Kumar sir, the former Joint Commissioner of Education, Mr. Ajit Kumar, and all the Education Department officials for MCGM, that is Municipal Corporation of Greater Mumbai, and participants of the online survey. Thank you for a patient listening on the last day of the last session of this conference.
Thank you, ma'am. Any questions from audience?
Thank you for such a super informative session, ma'am. I request Dr. Arun Gachare sir to felicitate Dr. Neeta Ghate, ma'am. I also request Dr. Sangeeta Lodha, ma'am, to felicitate Dr. Arun Gachare sir. Oh. For our next session, which is a panel on surgical pearls, I humbly invite Dr. Jyotsna Kulkarni, ma'am, on the dais. I also invite the speakers, Dr. Babulal Agarwal sir, Dr. Praveen Gad Singh sir, Dr. Satish Kapadne sir, Dr. Amit Raut sir, and Dr. Prashant Patil sir on the stage. Pediatric surgery is an important and inalienable arm of pediatricians. Let us see what this elite panel we have today has to say, what we should do before giving the patient in their hands and after they have left the operation theater. Over to you, ma'am.
Good afternoon, everyone. Dr. Mandar Vaidya and Anita Gangurde are not in Nashik, so they are not with us today. We are happy to clear some of the common misunderstandings regarding surgical patients, which we see in day-to-day practice. We thank the organizers for giving us this opportunity. We are going to start from where it all begins. Agarwal sir, which is the best time for anomaly scan?
For anomaly scan, actually, we should refer patient for sonography at the age of 18 weeks. And 18 to 20 weeks is the ideal age because the fetus is grown well and we can pick up many congenital anomalies. And that's why it is known as anomaly scan.
Which anomalies should be referred to pediatric surgeon and which need not be referred to us?
In general, actually, all GI tract anomalies and renal anomalies should be referred to pediatric surgeon. Anomalies of limb, anomalies of the heart, and anomalies of the CNS should not be referred to pediatric surgeon. They should be referred to respective branches.
Which cases one would advise termination of pregnancy?
Normally, actually, antenatally, only one condition actually surgery is done in India. And that is also SRCC Bombay and Bangalore. in PU valves, actually they do shunting from fetus's bladder to the peritoneal cavity of the mother to drain the bladder. That is the only surgery that do not done regularly and results are not very good. It causes, many times it causes fetal loss also.
Sir, which cases we would advise termination of pregnancy or termination of fetus?
Termination of pregnancy mainly CNS like meningomyelocele and pertaining to meningomyelocele, hydrocephalus, folic acid deficiency, this thing, and then severe cases of posterior urethral valves, where actually it is difficult to understand what is severe and what is, but severe cases of posterior urethral valves where there is, where actually after birth, you see patient is having severe renal failure type of picture. So that those things actually we can ask for the termination of the pregnancy. Routinely, actually all renal anomalies and GI tract anomalies are treatable postnatally. So those anomalies should not be terminated, except I think duodenal atresia, where we should be careful of Down syndrome also. And if we see a patient is having Down syndrome, we may advise for termination of pregnancy.
So basically where the child is going to have fairly normal life, we don't need to terminate and scare the parents. Okay, does a neonate need to be rushed to OT after delivery if any of the congenital anomaly is present?
I think except gastroschisis, no anomalies is required to operate urgently. So I think patient should be stabilized for 1 or 2 days and then should be referred to pediatric surgeon, because no GI tract anomalies like fistula, diaphragmatic hernia, or even atresias and all those things doesn't require emergency surgery. They can be done after 1 or 2 days of stabilization of the patient.
Okay. Hypospadias is the commonest congenital anomaly that we deal with. Incidence is very high, 1 in 250 live births. Dr. Praveen Garsing, when should first consultation be done for a hypospadias patient?
Hypospadias being a genital anomaly, normally the parents of the child, they are very anxious. So to reduce the anxiety and do a proper counseling as early as possible, if we can consult, we can reduce the anxiety.
Yeah, so as soon as it is detected by the pediatrician or maybe even relatives, the patient should be referred. Okay. What is the ideal age for surgery?
The ideal age for surgery is around 1 year of age. That is the commonest, but most of them present at 4 years, 3 years, 5 years. That also can be done, but the ideal age is 1 year of age.
Basically, before the child starts attending school at 3 years of age, as Praveen will say later on, there are problems, 1 or 2 sittings may be required. So we want to complete them before a child starts attending school, because there are common urinals in the school. So stream and all those things are a concern. So by 1 year, child should
1
come
year
for
is the
surgery.
idealist.
Yes. What are the complications of hypospadias surgery, and should they be looked upon as failure of surgery?
The complications can be classified as the early class and the late one. Early infection, retention of urine, then the swelling is there. In the late complications like fistula, then failure, we cannot call it as a failure of surgery. Basically, in many of the cases, we require 2 stages of surgery. And sometimes fistula is considered as a fistula closure, which is a minute surgery. It is not exactly a failure of the surgery. So in hypospadias, 2 stages are acceptable in a patient.
Yeah, so it's a very delicate surgery. Even the best of surgeons have fistula formation rate. So closure of fistula, and it's not as complicated as the first surgery. So it should not be viewed as failure of surgery. Okay, next condition that we are going to discuss is undescended testes. Dr. Satish, what is the ideal age for surgery for undescended testes?
Yes, diagnosed at birth, the ideal age of surgery is 6 months. If it is not, the testis is not descended by 6 months of age, then we should go ahead with surgery at 7 to 8 months of age.
Yeah, so basically you will counsel the, say, a newborn that it can come
Yes.
down naturally. Yes, how to clinically differentiate between retractile and undescended testes?
Yes, this is the commonest thing when the child comes in OPD. You have to differentiate between retractile and the undescended testes. So clinically, what you get, the undescended testes, the scrotum is not well developed. While in retractile testes, the scrotum is well developed. When you ask the child to squat, generally retractile testes, they generally come down easily, where undescended testes, they don't come down easily. And when you ask the child to lie down supine and you milk the testes from inguinal region to scrotum, retractile testes can be easily brought down up to bottom of scrotum, where undescended testes you cannot bring down to bottom of scrotum. So these are the three most clinical important findings you should look in OPD while
Yeah,
diagnosing.
this is a common reference, a patient is referred for undescended, but actually he has, the, the picture has a clue that that half of the scrotum is not developed. Okay. Which type of undescended testes should be operated laparoscopically?
Yes, so those were non-palpable testes, basically. When you're not able to palpate the testes by your manually with your hands. So these can be abdominal testes or atrophic testes. So that those testes should be operated scopically. And there is one condition where the testes is at the deep ring, and you cannot bring them down with open surgery because the testicular length, vessel length is very short. In that case, laparoscopy is gold standard.
Yeah, mobilization of vasculature is much
Yes.
better laparoscopically than in open surgery. Okay. What is the gravity of situation for bilateral and non-palpable testes?
Yeah, so whenever there is a bilateral, especially non-palpable testes, you have to investigate those children for DSD, intersex disorder. So you should refer them to pediatric endocrinologist and do all necessary investigations, and then you can take a further action.
What are the clinical features of torsion testes?
Yeah, torsion testes, if it is an infant, there will be excessive crying. If there's a bigger child, there will be excruciating pain in the scrotum
in a newborns. So in a neonate, EC scan is preferred over DTPA. So DTPA after 1 month.
Yeah, DTPA should not be done before 1 month of it. What is the natural outcome of this condition, PUJ obstruction?
All the hydronephrosis which are picked up on antenatal ultrasonography do not require surgical intervention. Only 20 to 25% of cases will require surgical intervention. Remaining 60-75% of the cases, they will be resolved spontaneously. If you consider about the criteria on the USG, then it is all the AP diameters less than 10 millimeters. They have a high chance of resolution. And considering the Society of Fetal Urology grading, grade 3 and grade 4, there is where there is a central splitting of the renal system with extension to the chylices, and grade 4 is extension to the chylices and dilatation with thinning of the parenchyma. In this grade 3 and grade 4, these cases will require surgical intervention. Function. In all these conditions, we operate on a pelviuretic junction.
Okay, what are the different surgical modalities available?
It's a surgical modality, open invasive surgery like laparoscopic pyeloplasty can be done in this scenario. Nowadays, robotic pyeloplasty is picking up. And the fourth is endoscopic intervention. But for endoscopic intervention, the success rate is very less. It's hardly 60-70%. So that goes very down the line. So better is open surgery or a minimally invasive surgery, which has got a success rate of around 100%.
Yes.
So that is preferred. And if you consider between open and minimally invasive surgery, cost is the only one negative aspect considering the minimally invasive surgery. If you go for robotic, again, cost is the concern. But there are benefits like scarless surgery or very minimal scar, less post-operative pain, lesser duration of hospital stay, lesser morbidity, and all these things in a minimally invasive surgery.
Who should do this surgery, urologist or pediatric surgeon?
Important question. See, the patient is a pediatric. That is first thing. And it is a pediatric surgeons who are dealing more with the pediatric conditions. Secondly, it's a congenital anomaly. Again, it's a pediatric surgeon who deals more with the congenital anomaly as compared to the adult urologist. Thirdly, along with the pediatric surgeon, he has a pediatric anesthetist and with the pediatric staff and the backup. And our team is trained to handle such small pediatric babies, especially neonates. So it is always a pediatric surgeon better in such scenario. And even in the medical legal criteria, it fits for a pediatric surgeon being a patient is pediatric and a congenital anomaly. So considering medical legal aspects also, it is a pediatric surgeon who tops the line for treating this congenital anomaly.
Yeah, we are more comfortable in dealing with pediatric patients, and we don't come to you for things like what is antibiotic dose, how much of IV fluid, it's part of our training. So yeah, pediatric surgeons should do it. Okay, when do you do follow-up investigation in an operated case of PUJ obstruction?
Okay, follow-up is done with the radiological investigations with ultrasonography done after 3 months after the surgery, and renal scan, that is nuclear scan, done 6 months after the surgery. Considering ultrasonography, you don't have to see, we have to tell the parents that see, ultrasonography might show hydronephrosis or a pelvic tasis. This pelvic tasis remains for a longer time. It can take 3 years to more than that, also 10 years, 15 years. So it can be a lifelong pelvic tasis. So considering ultrasonography, what we have to see is the temporoaxial growth of the kidney, which is occurring as the child grows. Second thing, we have to see whether the parenchymal thickness is improving as the child grows. So these two important parameters have to be looked up under sonography. So accordingly, we have to discuss with the sonologist to look for these parameters rather than for the hydronephrosis in an operated child. And considering the nuclear scan, which is done at 6 months, we have to see the rising curve pattern was there before surgery, whether the curve has gone down, parenchymal uptake has improved, PHAF has gone down, renal function is improved. All these things we have to see in the follow-up step.
Yeah, so purposefully I've included this IVU picture, though we do not do it routinely. How much of pelvis we resect, it depends on our on-table judgment. Lot of it remains behind, and the ultrasound picture comes as report comes as residual hydronephrosis. So don't get alarmed by that. The pilectasis, as Amit said, does remain for a long time. Agarwal sir, what is the ideal age for surgery for hernia?
Normally hernia is as soon as it is diagnosed, maybe in newborn, maybe in preterm babies, earlier on day one also we can operate. Even weight of 1 kg child also we can operate. So as soon as it is diagnosed, I think we should do the hernia operation.
What are the problems of conserving neonatal or infantile hernia?
Any hernia for that means actually if we conserve the baby, there are always chance of obstruction, and then obstruction leads to gangrene and all other complications. So I think hernia should not be kept waiting, and as early as possible we should operate.
Yeah, the incidence of or obstruction is has at 30% in neonates and infants. And second problem is that the testicular artery can go into spasm, and you may reduce the hernia, or it may automatically get reduced, but the testes will get fired and they all will land up with atrophic testes. So that is another thing we always say, that don't conserve a neonatal or infantile hernia, or for that matter, any pediatric hernia. Is laparoscopic surgery recommended for pediatric hernia?
For pediatric hernia, actually no laparoscopy should be done, because in laparoscopy we are piercing the peritoneum, and this surgery is so simple. Actually, we are doing all extra peritoneal surgery and hardly takes 10 minutes of the surgery. While in laparoscopy, it will take more time also, more expensive also. And main problem is that we are going into the peritoneal cavity. So without going into the peritoneal, if we can do such a simple surgery in 10 minutes or so, I think we should not advise laparoscopy in inguinal hernia in pediatric patient.
Yes. What is the correct age of surgery for hydrocele?
Compared to hernia, I think hydrocele we can always wait. Previously, they used to say that it may reduce by 6 months, but now latest investigations and researches show that you can safely wait up to 1 year of age, unless it is a very tense, big hydrocele causing pressure, and otherwise actually we can always wait up to 1 year of age. Ideal age to operate hydrocele, if remaining at the age of 1 year, I think we should operate.
Have you ever got a frantic call for irreducible hernia when actually it was a hydrocele? And how would you differentiate between the two conditions?
So many times we get a call because of the tenseness of the hydroceles, or otherwise if you see incomplete hydrocele, like hydrocele of the cord, which is very tense and we cannot reduce it. So many times actually we get a call that it is irreducible hernia. So you have to differentiate between hernia and hydrocele by simple test of transillumination, fluctuation, and if still in dilemma, you can always go for sonography.
So if you see in this picture, I can just change the heading and both will again look correct. Okay. Thank you, sir. Posterior urethral valves are a spectrum of conditions, ranging from simple to highly morbid cases requiring even renal transplant. Dr. Praveen, what is antenatal ultrasound picture of posterior urethral valves, and how is it different from PUJ obstruction?
Due to advanced antenatal sonographies, nowadays we can pick most of the renal anomalies antenatally. Considering the pictures of posterior thorax, we'll be getting a dilated kidneys, dilated ureters, distended and thickened bladder. And in PUJ, the ureters as well as the bladder are normal, only the pelvis and the kidney is dilated. In the severe cases, we will be getting oligohydramnias along with POS. Also, in the most severe cases, Potter's faces are seen, but this is in something around 2 to 3% of the posterior urethral wall cases.
Yeah, so basically lower tracts are normal in PUJ obstruction, whereas they are affected in posterior urethral valves. When to investigate after birth?
Uh, we should be investigating it as early as possible. After 2 days, we will be doing a sonography and maybe MCU under the proper coverage of the antibiotics, as well as the blood investigations as well using routine microscopy is done. In this, the chances of renal functions getting deteriorated are high. So we will be doing the renal scan, which is DMS scan after 1 month of age.
Okay. What is catheter trial in a case of PU valves?
Initially, the treatment for PU valve was diversion surgeries, but nowadays, due to the advanced minimal invasive surgeries, cystoscopic and fulguration can be easily done. So in catheter trial, what we see is we put a catheter for 2 to 3 days. And if after putting the catheter, the counts, the renal create values, all these things come down, that means a lower invasive, minimal invasive surgeries like cystoscopy will be useful for this patient. And this is what is called as catheter trial. If even with catheter, these things are not coming down, that means he will be requiring a higher diversion surgery.
What are follow-up investigations and follow-up treatment after fulguration?
Posterior urethral wall, I could say, is one of the most complex case in a pediatric surgery as well as a pediatric patient police scene. We should counsel at the initial stage only that the patient is going to require treatment, follow-up investigations for the long term. Post cystoscopic fulguration, the first follow-up is after 7 days, second is after 14 days, then 1 month, then 3 monthly, and then 6 monthly follow-up. The initial investigations which we will be doing will be both radiological as well as the pathological investigations. In radiological, USG is repeated 3 monthly, MCU is done 6 monthly, and scans can be done 6 monthly. While in blood investigations, we will be looking for the create value, the CBC, calcium, as well as there are chances of acidosis, so ABG is done.
So sodamine tablets
Sodamine, that will be coming, and after this, the treatment is given as per the renal values, and a chemoprophylaxis is to be given on a long-term basis in the form of nitrofurantoin or Septrin.
Dr. Amit, when do we investigate a patient of urinary tract infection?
So if it's a male child, more than one episode of urinary tract infection has to be investigated. If it is a female child, more than 2 episodes of urinary tract infection have to be evaluated or investigated. Or if the child has presented with a recurrent urinary tract infection history for you for the first time, you have to investigate the child aggressively. Or if the child is known case and he has come with a breakthrough UTIs, again, you have to investigate aggressively. Or if the patient with urinary tract infection comes with a presentation like urinary dribbling or retention of urine symptoms, then you have to investigate the child thoroughly. Or if you are suspecting some underlying anatomical abnormality, urinary tract infection, you have to investigate the child thoroughly.
Okay. When to do MCU and what to look for in an MCU?
Yeah, when you're suspecting that there is a urinary tract infection and there could be some underlying congenital anomaly like vesicular reflux, which we would suspect when the USG shows that there is a dilatation of the ureters along with the kidney, then we have to do the MCU. And this MCU has to be done under the cover of antibiotics, which are given for at least for 3 days. After 3 days of antibiotic cover, you can go ahead with MCU, provided the fever of the child has gone down if the patient presented with febrile UTI. What to look for in MCU is we look for initially the urethra. In urethra, we look for if there are any negative shadows of posterethral valve or like a urethral hemangioma, urethral polyp, or urethral atresia. In the bladder, we look for bladder diverticulum or uretrocele. Then in the ureters, we look for vesicular reflux. And then towards the kidney, we look for whether the kidney is dilated, if the contrast is reaching to the kidney. And if there is a vesicular reflux, which can be congenital common cause of urinary tract infection in children, then we have to see whether it is reaching up to the kidney. Then there are different grades of reflux, and depending on the grades of reflux, we have to decide the management.
So what is the conservative treatment for vesico-ureteric reflux?
If on MCU, you get grade 1 or grade 2 or grade 3 vesicular reflux, they have to be conserved. If the child does not have urinary tract infection and if there is grade 1, grade 2, grade 3 reflux, you can conserve the child. So basically conservative treatment will be of antibiotic chemoprophylaxis, which you start. And after 1 month, you call the child with a urine routine microscopy report. If the urine routine microscopy report will show that there is infection, then you advise culture. And according to the culture report, you can modify your chemoprophylaxis. If there is no infection, you just switch over to the different antibiotic. Different chemoprophylaxis options available, amoxicillin, cephalexin, nitrofurantoin.
Okay, what are the indications
Septran.
for surgery? Septran is.
Septran, yeah.
What are
Indi-
indications for surgery
Yeah.
for VU reflux?
Grade 5 vesicular reflux, then grade 4 vesicular reflux, then grade 1 to grade 3 vesicular reflux, which we have conserved and kept done on antibiotic chemoprophylaxis. If they start giving a breakthrough UTIs or present with recurrent UTIs, we have to consider surgery in those cases. Or grade 1 to grade 3 vesicular reflux who present with scars on a DMSC scan. Or any underlying congenital anomaly or abnormality which can lead to secondary to reflux. So that abnormality has to be corrected, and that time we have to consider for a anti-reflux surgery also. So all these conditions we consider for surgery. And on a DMSA scan, even if it is a grade 1 to grade 3 reflux, on a DMSA scan, if the renal function is poor, we have to again consider for surgery.
Okay. Long time back, many seniors had told me that they used to send the baby for bronchoscopy to KEM hospital, and next day the baby would come back with foreign body removal. All the credit goes to all the stalwarts in my alma mater. But such smooth outcome may not be possible, especially if the child has come in a bad shape like this one. It is very high risk procedure with high tension drama in OT. Complications like tear of bronchus, tension pneumothorax, and bleeding can be life-threatening. There can be incomplete removal of foreign body or failure to remove, both of which will require second sitting. We need good OT setup, appropriate instruments, expert anesthetist, and even experienced OT assistant for successful outcome. Every member of the team is important as margin of safety is very narrow. Cough persists for some time, but that's mainly because of the irritation of the cords, but eventually it will settle. Post-operatively, one check X-ray is required to rule out pneumothorax. So what we want to emphasize is that it's a very high-risk procedure and that should be counseled to the parents at the outset. Nowadays, we hardly operate on patients of intussusception. Dr. Satish, what are the contraindications and indications for hydrostatic reduction?
Yes, so rather than speaking about contraindications, mainly for any intussusception has two options of treatment. One is hydrostatic reduction and another is open reduction, that is laparotomy. So rather than indications, contraindications are most important for intussusception. So contraindications are like more than 48 hours of presentation, presence of acute small bowel obstruction in addition to intussusception, presence of abdominal distension, and clinically there is a guarding rigidity. You should not do hydrostatic reduction. Relative contraindication may be presentation more than 2 years of age where there is a pathological lead point present, and after doing hydrostatic reduction, chances of recurrence are very high.
What is the follow-up treatment after successful reduction?
After successful reduction, we generally do repeat UHG after 24 hours to see whether there is any residual or recurrent intussusception is there or not. And then after that, we can discharge the patient.
What are the options after unsuccessful? Can you attempt again? Are there any predictive features right at the outset to suspect a failure?
After first reduction, a successful reduction, if unsuccessful reduction, sorry, if we can reattempt the reduction after 8 hours, but after the 8 hours, then you have to go for laparotomy.
Okay. Who should do this procedure, us or someone else?
That is the most important question. It should be done by pediatric surgeon, because whenever the intussusception is diagnosed in counseling, we generally counsel that The best treatment is hydrostatic reduction, but there are chances of failure. So you have to keep operation theater ready, all the operation theater staff ready. If interception reduction fails, then immediately the child has to be shifted in operation theater, which others can't do. Others, they will just say that interception reduction nahi hua hai, you can just take away the child to pediatric surgeon. Because while reduction, if there is a perforation, if the child becomes bad, then it is an emergency. You have to immediately shift the patient in operation theater and operate. So it has to be done. It is a responsible procedure done by responsible person. So ideally, pediatric surgeon should do it.
So we are a complete package. We can deal with any problems that come. So we should be doing this procedure. Okay. Constipation is rampant in today's lifestyle with children eating lot of junk food. They are a very boring set of patients, but at times very difficult to treat also. Agarwal sir, how to differentiate between congenital and acquired megacolon?
Normally congenital megacolon or Hirschsprung disease, first sign will be that the delayed passage of the meconium. Normally meconium should be passed within 24 to 48 hours. If the meconium is not passed up to 48 hours and then passed on third day, fourth day, I think first suspicion should go for congenital megacolon, that is Hirschsprung disease. While acquired megacolon or constipation is late onset. Normally you don't see in younger children, except some children with breastfeeding. They may have constipation, but otherwise I think early sign of constipation is especially Hirschsprung disease is delayed passage of meconium.
Yeah, perineal soiling, if you see when you examine a patient, that is very, very likely to be because of habitual constipation. Okay. What investigations are required to diagnose Hirschsprung's disease?
If you suspect Hirschsprung disease with the history of delayed passage of meconium, I think first thing we should do is barium enema to prove our diagnosis. But there is a special technique of doing barium enema in newborn patients for Hirschsprung disease. We should not vacate the bowel. Like in other barium enemas, we vacate the bowel and then do the barium enema. But in Hirschsprung disease, we should not vacate the bowel and do the barium enema. And very thin barium should be used and not like 100 to 100 ml. It should be used till you see under screening. If you see dilated segment, that is the only limit to inject barium.
So you stop injecting as soon as you see coning, like in the first picture, and some amount will always go into proximal dilated colon. And don't flood the colon with basins because that will be difficult to pass in case there is Hirschsprung's. Okay. How is habitual constipation treated?
Habitual constipation actually difficult to treat. Doctors can only guide. Actually, mother should take care of the child. And it is divided into three parts. First is toilet training by mother. Actually, mother only can do the toilet training. Second is medication. Medication we can suggest like softener, stool softener. And the second part important is diet, change of diet. Stopping all junk foods is the most important thing. And then along with softeners, we can treat this constipation. It may take 4 to 6 weeks or maybe 4 to 6 months also to completely recover from the constipation.
Okay. Few common conditions I'm just going to rush through. Labial Seineke separation is an OPD procedure done under lignocaine jelly application. It doesn't require any OT setup, doesn't even require any incision. Happens because of relative estrogen deficiency. So mother is instructed to apply estrogen creams and manually keep them separated because they have tendency to readhere. Collagen dressing works wonderfully in pediatric patients. The trick is to apply it within 24 hours to first and second degree burns. Cystic hygroma resolve completely after intralesional injection of bleomycin. Usually 2 to 3 injections are required. Growth of large ghastly looking hemangiomas can be halted very well with oral beta blockers. So to conclude, what we want to emphasize is that surgical neonates need not be rushed to OT immediately after birth. They all need some stabilization and initial treatment. Age of surgery for all the congenital anomalies is fairly fixed. When you counsel relatives to see a surgeon at a later age, it is important to specify at what age to consult a surgeon, because मोठा झाल्यावर बघू is a common advice, and how the relatives will interpret is not in our hands. So some patients come at 2 years, some at 5, some at 10, with things like undescended testes and hypospadias. We don't want that to happen. Thank you.
Thank you for this wonderful panel discussion. Since we have a few minutes left, we can take some questions from the audience. Any questions?
No questions, so it was a success. I noted that. And I also noted all those who said will come but didn't come.
May I now request Dr. Jyotsna Kulkarni ma'am to felicitate all the speakers. Dr. Babulal Agarwal sir, Dr. Praveen Gadsing sir, Dr. Satish Kapadne sir, Dr. Amit Raut sir, and Dr. Prashant Patil sir. I also request.
Actually, it should be other way around. We all should felicitate madam because she has taken a lot of efforts.
I also request Dr. Tripti Mahatme ma'am to felicitate Dr. Jyotsna Kulkarni ma'am. Thank you so much, everyone. We move to the valedictory function in Panchvati Hall. Thank you.
Thank you, madam.